Ooh, this slide is busy, isn't it? So this slide talks about vital signs. Now remember, part of our job is to ensure that the baby is safe, right? Because it just is now it's on its own. It has to learn how to breathe and learn how to eat and maintain its stability. So we need to make sure that the baby is actually doing that. So again, I apologize for the busyness of this. So we need to go ahead and check our vitals. Of course, when the baby is born, right? So if you are the recovery room nurse, you're going to check it, of course, when it's born. But if you are if you are the postpartum nurse and you are receiving this couplet, you want to check the vitals just like it says up here. And I put it in bold because in your ATI book, it was very specific about the timing of this. Every 30 minutes times 2, then every hour times 2, and then every 8 hours. I can't guarantee you're going to see this schedule happening in the hospital. But again, this is kind of the standard anyway of how one should check vitals on a newborn. You might find a policy in your facility that says otherwise. So, but I would say unless your policy says otherwise, you're going to want to go ahead and keep to these standards. Let's talk about the respiratory rate. So, babies should be breathing between 30 and 60 breaths per minute. Sometimes the baby can have periods of apnea, but when I say that, it's tiny periods. Like this says less than 15 seconds. Just a couple of times, and it might breathe like this couple like breaths pretty quickly and then stop, and that's all to be expected again. But if it's if the baby is tachypnic or it's has apnea longer than 15 seconds, you want to do some more investigation and figure out what's going on. You might hear some crackles sometimes, some wheezing in your lungs. Now it's really hard sometimes. It can be hard, especially as a student when you're learning, to be able to differentiate breath sounds from the heart sounds, because honestly, on an adult, our trunk is quite a bit larger than a newborn's trunk, right? You guys know that. So everything's kind of in the same spot. So I would, if you're going to assess the respiratory rate and the heart rate, I would do those things first, because you can the parent can hold the baby while you're listening to heart sounds, listening to lung sounds, okay? Once the baby starts crying, it's kind of over until it stops crying because you can't hear anything. But the baby can have some amniotic fluid still in the lower parts of its lungs. Now, crying will help to get that out, but you might notice you hear some kind of like crackling and some wheezing a little bit there. The book does talk about that could be a sign of infection. If you had an infection happening, you would see other things as well. Now, grunting and nasal flaring are a sign of respiratory distress. If you're watching your baby when it's at rest and when it breathes, it has nasal flaring, or it's grunting, which means that typically it's when the baby is exhaling, it kind of doesn't hold its breath all the way. It kind of breathes through the vocal cords, and I'll demo it when we're in class. I'm not going to do it here. I'll demo it when we're in class, but that's a sign that the baby is having some struggles, and we really want to investigate that further. You know your normal heart rate. The good news is that the normal fetal heart rate is the same as the normal newborn heart rate. So that's kind of a nice thing. And you can't have those fluctuations. If your baby's crying, it's clearly going to be higher than 160. Or if it's sleeping, it might be a little lower than 110, just like yours would be. So babies are just small people. Let's not forget that. So we want to kind of give it the same playing field, that we be fair about our playing field with that. Just like for your adults, when you're doing your adult assessment, you listen to the heart sounds for a full minute. With these newborns, do the same, which can be a challenge because babies do cry. Like I said, I often do my respiratory rate and my heart rate when the family is holding the baby or the baby is wrapped nice and tight, and I kind of slip my stethoscope in under the blankets and then do my assessment that way. Okay? Because once the baby starts crying, you can't hear a dang thing. You don't want to place your stethoscope on the fourth and fifth intercostal space. You know this, the same place you would assess, on an adult as well. Some babies will have murmurs. I can't really describe what it sounds like because, I don't know, it's kind of hard to describe, but it does not, your adult heart sounds the same as a newborn heart. It's just faster than newborn. But if something sounds adventitious or different, grab somebody and have them listen. It might be a murmur. Blood pressures in some hospitals are not routinely done on well babies. They may only do blood pressures with babies in the NICU. So if you're working in that hospital, you might not ever take blood pressures on newborns. But here are the norms in case you wanted to know what they are. And your temp is the bottom one here. So again, starting from the least invasive, I guess blood pressure and temp is invasive, but it's more startling to the baby. So then we'll do your temperature. Be mindful that this baby is at risk for hypo and hyperthermia until it can stabilize its own temperature. It's never had to do that before, so we want to give it a chance to be successful at that. If your newborn is chilled, and we call the baby that is chilled being experiencing cold stress, and we don't want that to happen because it can use up its brown fat. And we're going to talk about that in class. So newborns have periods of reactivity, we call it. Um, the idea behind knowing when these periods are is because you want to kind of capture these kiddos when they're awake, right? So your first period of, oh my gosh, I wrote creativity. Oh boy. That should say reactivity. Reactivit. I'm so sorry. The first period of reactivity is from the time of birth up until 30 minutes. So you want to, if the family, if your client really wants to breastfeed, this is when you want to start, because you've got an alert baby. They're looking around, they're licking their lips. If we can, let's get that baby to breast as soon as we can, because we know it's going to be inactive right following too. So it begins to kind of tuck her out and catch up on its sleep. And if we don't get this baby to breast early, it's going to sleep right through it. So our second period of reactivity, it can be about 2 to 8 hours after birth. So again, think about if we miss this window, we could be at quite a bit before we can get this baby reactive and awake so we can get the baby to breast especially. And a lot of times we talk about reactivity when we're talking about breastfeeding, because as much as breastfeeding is, I don't know, people say it's whatever you're supposed to do and all of that, but sometimes it's hard to do, and it's even hard when you've got a sleepy kiddo. So let's see if we can get that baby to breast in this first period of reactivity. So in the second period of reactivity, we are now waking up again, looking around, figuring out where we are. Baby becomes responsive. You might notice that sometimes when it's waking up, it might cough and gag. It's because it's been sleeping, and it might have that mucus that gets stuck on its throat. So that's okay. We can go ahead and either pick up the baby and kind of pat it on the back, or we can use a bulb syringe to clear the secretions and then spend time with the baby. Thankfully, people are starting to look at the fact that newborns can experience pain. All right. So there's different ways that we can measure pain, and I talk about the two, a couple of them in this slide and in the following slide. Depending on what hospital you work at or what facility you work at, they're going to use different scales. But I'm going to talk here about the Newborn Infant Pain Scale, which is NIPS. And, it's just like other things. You watch something and you assign a number. So the NIPS scale is used with both preterm and term infants. There are 6 indicators, each is scored with a 0 or a 1. A score of greater than 3 indicates this newborn has pain. So when you're assessing this baby, you want to assess it for a full minute before you assign it a number. The next newborn pain scale we're going to talk about is something called CRIES, and these are all acronyms, which, as in nursing, they're everywhere, right? CRIES stands for crying. R is required increased oxygen administration. I is increased vital signs. E is expression. And S is sleeplessness. This tool we can use to nicely measure post-op pain in newborns. The higher the score, just like the other one, the higher the score, the greater the pain. The maximum score you can have on this one is 10. So now we're going to talk about the newborn meds that babies get after birth. Before I get further, I want you to kind of touch on the fact and let you know that parents can refuse all newborn meds. That's within their right to do. I often I see it more as an opportunity to educate more than anything else. I can't remember when it was, but a while ago, people were talked about how immunizations cause autism and all of this stuff. And then all the research came out and said, no, it doesn't. So there was lots of education at that time in my career that we talked to these parents about it. But ultimately, the decision is theirs. If the family does refuse to immunize or give newborn meds to the patient, we just document that and let the pediatrician know, and then that's all we as nurses can do, right? These are not our babies. We're just here to kind of help the families out. So the first medication we're going to talk about is this one over here on the left, erythromycin ointment. It prevents ophthalmia neonatorum, which is caused by gonorrhea or chlamydia. And you guys might get a chance to do these meds when you're in clinical, which would be great. So how you're going to give it, and there's a picture of a nurse doing that here. You want to use gloves when you're giving meds. And ideally, you want to have the light over the baby to be turned off. Babies are used to being in a dark environment, so if the light's bright in their face, they're going to squint their eyes. So ideally, you want to, you have babies under the warmer to have you give the meds. Turn the light off on the warmer, so the baby has a chance to open its eyes. So what you're going to do is dim the light above the baby, and you're going to open up the baby's eyes as best as you can, and apply a ribbon on the lower canthus of the eye. You're going from the inner to the outer. And as the baby opens up its eyes and blinks, it gets absorbed. It looks like Vaseline, so it's not really a drop. It's kind of thicker like Vaseline. We typically want to wait till after an hour after the baby is born, because this might get in the way of bonding. So we want to let the parents hold the baby for an hour or so. Some hospitals wait longer than that, but before you give the meds. The second one is the vitamin K. This actually is not an immunization. It's truly a vitamin. We give it to prevent hemorrhage because the baby's gut is immature and it doesn't produce the vitamin K, typically until about day 7. So what we're giving is a half. Most of the time it's a half, but the literature says a half to 1 milligram. I am using the vastus lateralis muscle. Now, I put this picture in because this is not what you guys are used to seeing. You're used to seeing little vials maybe of medication. Some hospitals use this more Carpaject system. So if you're at a hospital that uses that, your faculty will show you how to use it. You may not give newborn meds without your faculty. Okay, this is something that you need to do with your faculty. If your parents refuse medications and they want the baby circumcised, the healthcare provider will not circumcise the baby because, again, without this, the baby can bleed too much. All right, so just kind of know that. So the last immunization, or the other medication that the baby gets, is hepatitis B vaccine. We have to, of course, have informed consent because we're giving a vaccine. I wrote down how often your newborns or your babies at this month will get the hepatitis vaccine. They get it at birth, 1 month old, and at 6 months old. Sometimes the client is hepatitis B positive. So if your client is hepatitis B positive, the baby will get this hepatitis B vaccine and will also get the hepatitis B immunoglobulin, and it's known as HBIG, okay, within 12 hours of birth. All right, so just kind of know that might be an option there for you too, depending on if mom's hep B positive or negative. If you're going to give both of these meds, you're going to give one in one leg and one in the other. Most of the time it doesn't matter which leg it goes in, but you don't want to give them both in the same leg. So this slide talks about some laboratory tests that are done on the newborn. The first one we're going to talk about is metabolic screening or the PKU test. So a little bit about PKU. Maternal fetal ketonuria, or PKU, is a maternal genetic disease in which high levels of phenylalanine, I'll have to write it because I can't say it, so I'm going to write it so you can see how it's spelled. Maybe you guys can pronounce it better than me. Hold on, let me get my little pen here. PHENY. You see why I couldn't pronounce it? I always leave out that one of those A's. Anywho, this is an amino acid, and what happens is that in moms who have PKU, this is very high in their system, and it builds up in their body, so it keeps getting higher and higher in their system. Elevated levels of this that I can't pronounce are dangerous to the fetus. It can cause intellectual disabilities as well as behavioral problems. It's caused by a defect in the gene that helps create an enzyme needed to break down this. People with PKU are advised to eat a diet that is low in phenylalanine. I guess that's how you say it. 3 months prior to pregnancy, the clients need to be on a PKU diet. Clients with PKU have their blood phenylalanine levels monitored during pregnancy. We require newborns to be screened 1 to 2 days for PKU after birth. If it is positive, if PKU test is positive, a strict diet is followed. The child with PKU can lead a normal life as long as it follows the diet, okay? So it's mandated in all states. Can the parent refuse? Yes, the parent can refuse, all right? But it is something that is mandated, and they would just sign the refusal documentation. We definitely do the heel sticks, like I said, and I put a picture here on how we do heel sticks. You want to poke the baby on either side of its heel. Sometimes we warm the baby's foot because sometimes, well, you're going to learn about acrocyanosis when you come to class, but it's really common for newborns to have something called acrocyanosis in the early parts of its life. What that means is that the body is trying to keep the blood into the important, quote, organs of the body, the heart, the liver, the lungs, the brain, and the hands and the feet kind of fall low on that priority list. And that's normal. But what that means is that the hands and the feet can sometimes be kind of purpley, and they can be cold. So if you're going to try to do a heel stick, it might be a good idea to put a heel warmer on the baby's heel. It'll bleed a little bit better for you. We also do newborn hearing screens. That's required in most of the states now. It's actually really nice that we do that. There's oftentimes hospitals will contract with companies to come out and do the newborn hearing screens before the parents go home. So next we're going to talk about a circumcision. A circumcision is a surgical removal of the foreskin of the penis. It's up to the parents if they want to do it or not. It is something that is a consented thing to do, so the healthcare provider will give informed consent, and the parents will agree to do it, and they'll sign the consents. It does not done immediately following birth because the vitamin K is at the lowest point at that point. So we don't want to put the baby at a risk for a hemorrhage. We usually do it before the baby goes home, usually on discharge day or the evening before. Everything here, you guys, this is not my opinion. This is things this is literature that supports this, okay? The benefits of a circumcision: easier hygiene, decreased risk of UTIs, decreased risk of STIs, including HIV, preventions of penile problems, decreased risk of penile cancer as well. So some reasons we don't do it. If a baby's experience any of these things, they will hold off on a circumcision for a while. If the baby has hypospadias, which means that the urethra is on the underside of the penis, they will hold off on a circumcision. If there's a history in the family of bleeding disorders, and again, I already talked to you about this, if the parents decide they don't want to do the vitamin K administration. So this slide talks about how you actually do it. There's videos on the ATI website. When I used to work in the nursery way a long time ago, we didn't do anesthesia for circumcisions. I feel like people just kind of didn't think it made a difference to give these babies anesthesia. Now in most hospitals it's required. They either can do a nerve block right above the penis, or they can use some numbing gel on the skin so the baby has something. We also used to use 4-point restraints back in the day when I was brand new in OB. Nowadays we usually only use the leg restraints, so you'll see a little bit different there. There are non-pharmacologic methods that will help as an adjunct to pain meds that you're giving this baby. Babies like to be swaddled and have non-nutritive sucking. So you may look at this picture and be like, well, gosh, how would I swaddle with this contraption here? What you do is you swaddle just the trunk. So you have it nice and tight around the baby's head and around the shoulders, but its bottom is sticking out. So that way there is some swaddling that's happening there. Also, babies like sweeties. This is the picture of. I know you can't read that. You just trust me. It's almost like sugar water. You can put it on a pacifier and they can suck that, and the glucose in that will really kind of calm them down. There's different ways, different devices you can use to do a circumcision. The device that is used is going to be the preference of the person who's doing the circumcision. That's how they were trained, and that's what they're good at. And I do believe most of my kids in my class get to see a circumcision, so that will be good for you guys to see that and watch the whole timeout process. A Gomco clamp looks just like this. I have one I'll bring to class so you can actually see it, a Gomco clamp. But what happens here is they put this metal, it's not that big, it looks big in this picture, but they put the metal clamp kind of lay it on the baby's belly, and the penis is coming through the opening here, and this is a little metal piece here. They put this little metal piece on the head of the penis, so it's safe and covered, so you can't cut the head of the penis. And then you use scissors, and I've seen a scalpel used too, to kind of cut the foreskin off, and then you have that done. I've never seen this one done, so I can't really personally speak to that. In all of my years and being an OB nurse and working in this department, which has been since 1998, a long time, I have never seen that one done. I have had one student who's seen it, so it is being done, but not. I really can't comment on that one. A Plastibell is something these are the two that I've seen. So Plastibell is you get the results the same, but there's the different equipment. It's less equipment. All this is a piece of plastic, honestly. So there's this little piece of plastic guy here, and this fits right over the head of the penis. You can see it there. And then they have this tie. It's a very thin tie, and they tie it around the bottom of the plastic right here, make a nice little knot here. Then they take either a scalpel or these scissors, and they're going to cut the foreskin off. So what's left is the penis with this little plastic, that's why it's called a Plastibell, over the head of the penis, and there's a hole there, of course, for urine when the baby voids. But then this little stick thing here gets snapped off. All right, so those are the three different kinds of circumcision tools that you might see used. So your policies of your hospitals are going to indicate how often you should assess your baby and all that jazz. This kind of comes out of your book, so it might be a little bit different. How often you should assess your baby. If there's bleeding or oozing noted, you can put some gauze on it. You definitely don't want to have really too tight diapers on because you have this open sore there. You can give baby Tylenol. That's what this is. I've never had to do that, but that doesn't mean you can't. It's not you don't do it. It just means that I haven't ever had to do it. Something that I usually do, doesn't matter how this baby is circumcised, we take the baby into the nursery to do it. They don't do it at the bedside. Very few hospitals will allow family in there. Most of the time it's just the docs and the nurses. So bring the baby back, check the bands, of course, and then I take the diaper down and I show the family. I show the parents, because I want them to know what it looks like right now. And then I tell them, if you notice any bleeding more than this or any oozing, I need to know. Now remember, a lot of times they want the circumcision done, but they really don't. They've never seen it, and to see this on a newborn can be kind of startling. So I want to be there when they see it for the first time. So this right here, this picture is a picture of a Plastibell circumcision. So you can see it's a little teeny tiny thing, and this is this little twine, and all that's left is this little plastic guy, this little like ring thing, and the head of the penis is right there. We're going to talk a tiny bit about congenital critical heart disease, CCHD. So congenital heart disease is the most common birth defect, and it occurs in 8 in 1,000 births. We now screen for this in most hospitals, which is very nice. Critical congenital heart disease is associated with hypoxia during the newborn period and requires intervention in the first few months of life. How do we screen for this, you might ask? If you're not asking, I'm going to tell you anyway. So how we screen for this, you take the baby to the nursery, and there's 2 pulse oxes. So you're going to put one on the right hand and one on either foot. And you want the baby to be nice and still and quiet. So you don't want it crying and being bothered. Keep it wrapped up. We talked about, how it likes to be swaddled. Just stick out the hand and stick out the foot. And you're going to get a reading on the pulse ox, and it'll let you know, and based on the reading, you know if you've passed or you haven't passed. If it is negative, it's a pass and you're done. If it's a positive, that means that it's a no pass. Rescreen, and if it's still a positive, which is a no pass, you want to follow your hospital policy. Most of them will have you call the neonatologist on call to follow up, okay? We do the CCHD screening as close to discharge as possible. You want your baby to be at least 24 hours old before you do it. So this is an algorithm. Please don't memorize this algorithm. It's just for your reference. I got it from the CDC website, and it tells about the steps to do the screening, right? This is how old your baby is, and then if you get this result, do this. So just in case you're curious, I'm not going to test you on it, but I do think that in case you're curious, I wanted to give you a reference to look at. Finally, on this lecture, we're going to talk about newborn nutrition. We're going to talk about the normal weight loss for these little guys, the nutritional requirements for breastfeeding, as well as bottle feeding. It is our job not to put our opinions on our clients and to educate the client regardless of how they're going to be feeding their baby. This too is a very busy slide, and I apologize. Nutritional needs for the newborn, that's to where we are. We're talking about this little guy here. So what's normal? It is normal to have a weight fluctuation in these newborns. You can have a loss of 5 to 10% of its weight after birth. It's typically regained by a couple weeks old, but initially you can see this loss in their weight here. Most nurses in the hospital on postpartum, it's not uncommon to have babies being weighed every night, and that's why, because we're tracking this weight loss. Even though we know it's normal, we do still want to track it. This is the weight that the babies gain in the first 3 months. The babies, their fluid requirements are here, and their caloric requirements are here as well. So breastfeeding, if they're breastfeeding, there's no supplementation needed. We don't give babies water. Even when you're bottle feeding, we don't give babies water. Okay, there's not really a need to. They get all they need from either the formula or the breast milk that they're given. Infants should receive 400 international units of vitamin D a day. If your parent does not eat meat, fish, and dairy, they also should give the newborn vitamin B12. If they're bottle feeding or formula feeding, because you can actually, the reason I wrote it differently is because somebody can pump their breast milk and give it in a bottle. So the difference is if they're formula feeding. So formulas also contains all the nutrients the babies are going to need with the exception of fluoride and iron. They don't need supplemental water at all. They will give the newborns iron-rich formula until about 12 months of age, and you don't want to begin any kind of solid food to give to the baby until they're at least 6 months old. The research says if you introduce solids too early, there's an increased risk of food allergies. A little bit about breastfeeding here. So research says that breastfeeding is the optimal source of nutrition. And the American Academy of Pediatrics recommends breastfeeding exclusively for the first 6 months of the newborn's life. The idea of putting a baby on a breastfeeding schedule has kind of gone away. We used to do that. We typically don't unless there's a reason to. If baby's premature, they might wake it up to eat and those kinds of things. But you want to make sure the baby's eating every 2 to 3 hours, and we let them do demand feeding. Look for cues. Is the baby licking its lips? Is it kind of turning and trying to find food? That tells the client, all right, get ready. The baby's going to want to be eating very soon. If the baby has been sleeping longer than 3 hours, you probably do want to wake it up and see if we can get it to eat. Breastfeeding should occur 8 to 12 times in the 24-hour period, okay? In the first 3 days, we have this wonderful stuff called colostrum. Colostrum is this very nutrient-rich breast milk, and it provides passive immunity for all newborns. There are benefits to breastfeeding. There's a reduction in infection because of the IgA antibodies, rapid brain growth because of large amounts of lactose, the provision of protein that helps neurologic cell binding. It's easy for the baby to digest because it comes straight from its mom. The reduction in SIDS, allergies, and child obesity. Decreased GI infections, all kinds of things with ear infections as well. Reduction in postpartum bleeding. It helps with uterine involution. Uterine involution is, well, you already had the postpartum lecture. Remember, uterine involution is the uterus going back to its pre-pregnant state, and breastfeeding helps facilitate those contractions to help involution occur. And again, it doesn't cost anything. Doesn't make any trash. So that's another benefit as well. Whether the mother or the client chooses to breastfeed, use donor milk, or formula feed, we as nurses need to provide education and support without judgment. If the client chooses to bottle feed, we want to teach them how to be safe while doing that. They need not to reuse formula. They should check expiration dates, burp the baby after each half an ounce, and when they're feeding the baby to ensure that the nipple fills with milk and not air. So if somebody really wants to breastfeed, how can we help them? Remember we talked about the alert stages of the baby and how the first 30 minutes they're really awake? This is why this immediate skin to skin is so significant, because if the baby's awake, we can get the baby to breast right away. Increase our clients' fluid intake, help them express the colostrum on the breast, because the babies will turn to it and try to eat because they'll smell it. Demonstrate feeding positions. We talked about that in the postpartum lecture, the different ways you can hold the baby to feed it, so we can help them with that. Give them pillows and all kinds of supportive things. Remember, if the baby's on the breast, it should not hurt. It should just feel like pulling. If it hurts, the baby is on incorrectly. If you need to take the baby off the breast, don't just pull the baby away from the mom. You need to break the suction. All right? So what you want to do is take your pinky, or have the client take their pinky and slip it into the baby's mouth to break the suction. And otherwise, the baby's going to keep sucking on the nipple as you back it out of its mouth. You want to have the client watch for hunger cues, and then when they're getting ready to nurse, you want them to hold the baby in the position that they chose, and you want to stroke the baby's chin and cheek with the nipple, so it can kind of turn towards it to latch. Burp in between twitching breaths. Make sure you let them know that breastfeeding stools don't look like stools that they're used to seeing. Exclusively breastfed baby has loose, pale yellow, mustard seedy stool. It looks like there's seeds in there. That's okay. That's just a breastfeeding baby's stool pattern. If we're trying to not have nipple confusion, the literature says to not introduce bottles or pacifier before 3 to 4 weeks of age, because if you do it too early, it will help the baby can get confused. Be mindful that everything the parent takes in their body, whether it's medications or food or drink, crosses into the milk and out into the baby. So be mindful of that. Don't drink alcohol. Don't eat gassy foods. If we are going to go ahead and store our breast milk here, we can store it at room temperature for up to 8 hours, refrigerator for up to 6 months, freezer for 12 months. So that's a long time. If you have frozen breast milk, don't put it in the microwave to defrost it. All you got to do is put it in warm water in the tap, and it defrosts right away. But once it's defrosted, you can't reuse it. Just throw it away. There are varying stages of human milk and its production. Initially, colostrum is present in the breasts. Colostrum starts forming during pregnancy, and in some women will leak even before they deliver their babies. Colostrum is present for 2 to 4 days following the delivery. It can be slightly yellow tinged, not truly a white color. It's creamier than most people actually expect. They're kind of surprised when they see it. Colostrum is high in proteins, vitamins, and minerals. Because it's typically creamier than other stages of human breast milk, the newborn has to really work hard to get it, which means that you have to have a really solid latch on that baby so it can pull the entire areola to get that colostrum out. It promotes the formation of lactobacillus flora in the digestive tract, which helps protect the infant from illness. Additionally, it has a natural laxative effect, assisting the newborn to pass meconium stools, which will help decrease jaundice. So all kinds of good things. Then we have our transitional milk that comes in. So typically that follows the colostrum, and it lasts until about 2 weeks into the postpartum period. If you ever hear a mom say or a client saying that her milk has, quote, come in, this is what they're referring to. They typically feel heavier in the breast because there's more volume in this transitional milk. The babies don't need much colostrum to meet their nutritional needs, but then as the transitional milk, they need more volume for that. It's high in fat and calories, but it has less protein than colostrum does. By about day 5, most mothers are producing 16 ounces of milk a day. So now we're on mature milk. So mature milk follows the transition milk stage. It is 90% water. It is thinner than whiter than its above counterparts. Sometimes it can even be a little bit blue tinge, kind of like non-fat milk kind of looks like it has a blue tint. This kind of is the same. The milk that the newborn eats at the beginning of the feeding is called fore milk, this first one here. So when it's first latching on, it's getting this fore milk. It is watery in consistency, high in lactose and vitamins, and satisfies the newborn's thirst. Following the fore milk is the hind milk. The hind milk has more fat, and it satisfies that hunger, and it lasts the baby, how do I say it? It satisfies the hunger longer, I suppose. And it promotes the weight gain in these little guys too. Remember, maintenance of lactation is dependent on frequent and efficient removal of milk from the breast. So you got to have that baby on the breast to keep those breasts empty so the body keeps making more milk. So look at the slide. You can see the difference in the color, the amount, and the consistency of the colostrum, the fore milk, and the hind milk. So now I'm going to teach you about a latch score. It's yet another acronym like everything else is, but a latch score is used to assess the newborn's ability to latch and suck efficiently on the breast. I'm sure you're going to see this in your rotations. Postpartum nurses use this all the time. So the word latch is an acronym for L for latch, A for audible swallowing, T for the type of nipple, C for the comfort. We're talking about the comfort of the breast. And H is for hold. All right, so again, you're going to assign each one of these a number. The goal is to get the most points at the end of our adding here. So there can be some obstacles in breastfeeding. You can have sore nipples, absolutely, because you've got a human that is sucking on your breast a lot of times during the day, and that can be painful. So you want to make sure that your baby is in the right position. Some, especially primes with our moms here, some moms think that any latch is a good latch. And again, especially our primes. They're just so desperate to breastfeed and they're so tired. We have to educate them that this is not in fact true. We want to make sure we have a really good latch. We want to have the tongue to be under the nipple. So what you're looking for when you stroke the baby's cheek and chin and mouth and lips with the nipple, the baby's going to open because we have that reflex, and it's going to kind of curl his tongue like a little taco tongue, and the nipple's going to lay right on top of that curled tongue. Once the nipple is on the tongue correctly, the baby's lips will flange outward, and you should see most of the areola in the baby's mouth. You want to listen for swallowing. Now, it's pretty rare to hear gulping. Like if you're swallowing a big glass of water, you're not going to hear that. Swallowing it almost sounds like a little click. It has to be very quiet in the room to hear a newborn swallowing. If a mom's having sore nipples, she can go ahead and rub Express breast milk on her nipples after she feeds the baby, because that is natural and it will just soak in and it will help heal those nipples right up. And then let the nipples dry after feeding this baby. She might experience some plugged ducts. That is caused by a decrease in the milk flow. If there's decreased milk flow, it causes that obstruction and a hard lump. If the client feels this hard lump, you want to instruct them to massage the area, put on some warm compresses, and that should kind of massage that out. Keep feeding the baby as usual. You want to start with the affected breast first. So if she's got this plugged duct on the right side, you want to have the baby nurse on that right side. Definitely encourage frequent feedings. Make sure that the bra that they're wearing is not too constricting. Be careful of underwires, and increase fluid intake. So a bit about formula feeding, and I kind of touched on it, I don't know, like 4 slides ago. Formula does provide an adequate source of nutrition for these babies. You definitely want babies to eat about every 3 to 4 hours. You might have to wake them, but once they're gaining weight, you can feed them on demand. There's different kinds of formula. You can have the concentrate, which basically you have a concentrate, ready to feed, and powder formula. It just depends on the client and what they prefer to use. Make sure the bottles are clean before you make the formula. You can put them in the dishwasher or wash them with hot soapy water is fine. Once you prepare the formula, it can stay in the refrigerator for up to 2 days. We don't want to use the formula past the expiration date. Gosh, I have made all kinds of little typos here. I'm so sorry. You want to make sure when you're holding the baby that it's kind of in like a semi-Fowler's position, but not supine. You don't want to prop bottles and put the baby flat. It's not good for it. Discard any formula that you did not use because we don't want to have it growing bacteria. Some signs that your newborn is gaining weight. The stools are going to be soft and yellow. They're not going to be seedy mustard-like like the breastfeeding stools, but they'll be soft and yellow stools. And we should have 6 or more wet diapers a day. So there can be situations that can interfere with newborn nutrition. The first one is sleepiness. Babies who are tired don't want to eat, especially if they're breastfeeding. If you're turning a bottle upside down, the milk just kind of comes out. So if they don't eat it, it runs all over their face. But breastfeeding, you have to really work hard to get the milk out. So if you're kind of having this struggle with this baby, unwrap the baby because that'll startle it and that'll wake it up. Change the diaper, talk to it, and as soon as it's awake, let's see if we can get it to eat. You can have a fussy baby, and babies who are crying are not going to eat. So you want to make sure, swaddle them, see if you can get them to settle down, hold them, rock them, turn the lights down, talk quietly to them, place them skin to skin, and once they settle, let's get them to eat. You might hear something called failure to thrive. Failure to thrive means we have slow weight gain on these babies. You can have it whether you're breastfeeding or bottle feeding. If they're breastfeeding, some things you can do to help this is make sure, again, I go back to this over and over again, is your positioning and your latch correct? Let's look at that again. Massage the breast during feeding to help have more breast milk come out. Formula feeding, make sure the baby's eating enough formula, and assess for allergies. And when there's an allergy, they could be vomiting and they could have excessive spit up. So this slide actually doesn't have tons of information on it for you to see, but behind the scenes, there's a ton of information here for you guys. So our role as a nurse when a baby is born is to assess their adjustment to extrauterine life. So what you can kind of picture, what you guys are going to see in clinical is at most of our hospitals, and honestly, it's most of the hospitals around us for sure, as long as staffing is okay and those kinds of things. You're going to see a team of nurses for the baby and a team of nurses for your client, your laboring client, okay? And if you've got 2 babies, you should have a team of nurse for each baby, right? That way, until the baby is stable, that baby has its own team, all right? So the best thing you can do as a nurse, no matter where you work, is to always anticipate things going south, right? In a perfect world, everything is perfect, but the best nurse, the most prudent nurse, anticipates things. Just like we've talked to you guys in the past, make sure you've got all of your equipment when you walk in the room. So in this situation here, it's best for the nurse, for us to always anticipate the need that we're going to have to resuscitate this baby. We always want to anticipate that because then we're prepared for anything. So what does that mean? And kind of like I have written here, it talks about, is there meconium stained fluid? Now remember, we've kind of talked about this a little bit in the labor lecture, and you guys might have seen this happen when you're in clinicals now, but the baby's fluid should be clear, which we've talked about. And if there's meconium stained fluid, there's a risk the baby can aspirate that fluid and have difficulty breathing. So we want to make sure that the fluid is clear. Are there multiple babies, twins, triplets, etc.? The more babies you have, the higher risk of the need for resuscitation, okay? So you want to make sure that you have your ducks in a row for that. Was the delivery difficult? And we talked about that in week 1. Was there a shoulder dystocia? Was there a cord prolapse? All these scary things we've talked about, were those things there? Because again, there's a higher risk of us having to step in and help this little baby transition to being its own human, breathing air and those kinds of things. What was your tracing like? And again, you guys know what this means and when we're concerned. So those are the things that we need to know. And again, are there congenital anomalies? What's the gestational age of this baby? Because the earlier the baby, the last thing for these babies to breathe, the last thing for these babies to be able to do is have the ability to breathe air on their own. So an earlier baby is not supposed to, if you will, be breathing air yet. So the earlier the babies are, they have a harder time figuring out how to breathe on their own. So what's the gestational age? That will really help you anticipate your needs as well. Well, so how do we find out if we need these things? If I'm the delivering nurse in charge of the labor, and you come in and you're going to be the pickup nurse, I use air quotes, you can't see me, but the pickup nurse, the baby catcher, whatever your hospital calls it, all you need to do is have a conversation. You're going to walk in, you're going to talk to your laboring nurse, and you're going to ask these questions. And some of it you can see on your own. I mean, you can look at the tracing. You know enough now to establish the variability. Are there lates? Are there variables? So you can ask your nurse, but honestly, your nurse might be busy. It might be a really quick report from your nurse, and then it's up to you to figure out some of these things on your own. Okay, you'll be able to know if there's multiples, but your laboring nurse wants to tell you what time they ruptured, was the fluid clear, so you'll know that. But you can look at the tracing and you can have a conversation with your labor nurse and find out how it's been throughout the duration of labor. So what happens? So you're there as the newborn nurse, and I'm there as the labor nurse. And you already know about the transitions of labor, so we've already talked about that. So now the newborn comes out. The labor nurse documents the time and make sure you guys are on the same page with that. And if the baby is stable, it will lay on the client's chest. And you, as the nurse, will have your gloves on because the baby has not been bathed yet. And you will go over to the baby and start stimulating the baby to cry. How you do that is by putting it on warm blankets. You don't want to put it on cold blankets because it will drop its temperature. So you'll see your delivering person, your doc, your midwife, whoever's delivering, will put a warm blanket on top of the mom's belly. Baby comes out, lay the baby there, assuming, of course, it's breathing. And you will then go over with your gloves on and start rubbing the baby down with the blanket. What that does, it does two things. It dries the fluid off of the baby so it doesn't drop its temperature, but it also stimulates the baby to cry. Okay, so then you are going to be able to start doing some of your assessments right there. This right here is called a bulb syringe. This was talked about in orientation, but you want to make sure that your bulb syringe is with you all the time, with the baby all the time anyway. So you'll see the delivering person suck out the baby's mouth and nose and make sure that the airway is clear. So oftentimes they use this bulb syringe here. Sometimes they'll use deep suctioning, like an endotracheal tube, but not very often. Most of the time, we're just going to go ahead and use the bulb syringe there. A couple of things I want you to remember. The first breath of air that your baby takes is the first one you hear. Remember, the baby's not breathing air inside. So when the baby holds its breath and takes a big breath in and starts screaming, that's its first breath that it takes, okay? So sometimes babies will start doing that as soon as it's born, and sometimes it takes them a second to do that, and we talk about that in the next slide. Our job as newborn nurses, which will be so now your job because we're saying you're the newborn nurse in this scenario, we need to understand that establishing respiratory function is the most critical extrauterine adjustment, which makes sense, right? If you can't breathe, you got a problem. Same with the babies. And they haven't breathed until you're right there in front of you. So sometimes it takes them a second to adjust. When the cord is cut, and then I know in the week 1 lecture, the home lecture, we talked a little bit about the foramen ovale and the ductus venosus, but these are the things that will close when the cord is cut. So let's go back to the conversation. We're going to pick up that we were just at. So we're at the delivery. The baby's out. You as the newborn nurse is over with the delivering family, drying the baby off, right? And again, we're going to go with the scenario that it's a well baby, that its heart rate is the heart is functioning, it's breathing. Okay, we'll talk about when it's not in a second. So at a minute, it is your responsibility as the labor nurse to do the baby's first APGAR, and we're going to talk about that right now. And then we do it again at 5 minutes, and that's kind of written up here, okay? Oh, I'm going to change my color because it's a green slide. Let's go to black. It's done right here. We do this at 1 and at 5 minutes, and it's a very quick assessment that your nurses are going to do. Now, what I want to make sure that you understand is as a student, I don't expect you guys to do this at the time of delivery. We do things really fast. I'd like you to watch for it, but honestly, we do it so fast, I don't want you to miss it. So we're going to talk about it. There is a video on your ATI website that will demonstrate how to do it, but like most demonstration videos, it's done very slow. So just keep that in mind. Okay, so what does APGAR mean? It's an assessment test that helps us understand, and at 1 minute and at 5 minutes of life, how is this baby adjusting? That's really what we're doing. APGAR is an acronym, and it's written right here, kind of what it stands for.
So again, we're going to assume that the baby is with its mom, and you're doing the assessment all at the same time. So it's been a minute, and you're going to do this assessment really quick. All you're going to do is look at the baby. First thing you're going to do is look at the baby. That doesn't take very long. Your baby's either going to be here or here. Now, I'll be honest with you, at 1 minute, most of the time it's here. Pink body, blue extremities. The word for that is acrocyanosis. Let me write it for you. Acrocyanosis is exactly what this is. What that means is that the body is trying to keep the blood to the really important organs, if you will. And the heart's a really important organ, the brain's a really important organ, the lungs, but the hands and the feet aren't as important. So sometimes babies are acrocyanotic. It's not uncommon at all. So you'll see that the body is nice and pink, but the hands and the feet, sometimes a little bit, higher than the hands and the feet, are pale or blue. Sometimes they're mottled, sometimes they're cold. That's all acrocyanosis. So it's normal for babies to be acrocyanotic, all right? So if your baby is, you're going to give it a 1. If it's not, you're going to give it a 2. Now, I'm going to be honest with you. This is only at 1 minute of life. This is a perfect child. It is pretty rare for babies to be perfect when they're 1 minute and 5 minutes old. But if you decide your baby is perfect, then you give it a 2. So the next thing you're going to do is you're going to assess the pulse. Now, you're not doing a heart assessment here because that takes a quiet baby for a full minute. Well, we're not doing that here. You're going to do a really quick assessment to get the heart rate. What you're going to do is you're going to have your gloves on. You're going to reach under and you're going to grab onto the umbilical stump. It's not going to, don't grab too hard because you're going to occlude it. Put your fingers there and I want you to count the heart rate. All right? If it's below 100, put the baby under the warmer and let's start doing compressions or something to get the baby's heart rate up. Hopefully it's over 100 because again, by now your baby's crying, heart rate's going. So if it's over 100, you're going to give it a 2 points. C is for grimace. That's where we are now. I'm sorry. G is for grimace. That's where we are now. All right. So look at your baby. Is it floppy? If it's flop, anything here needs to be under the warmer. Okay, anytime you have somebody here, take it away from its parents and put it under the warmer. That's a problem, all right? But so look at your baby. Again, is it grimacing? Is it, a lot of times we can assess this by using the bulb syringe. We put the bulb syringe in the baby's mouth, and if it kind of spits it out and makes a funny face, they're responding to stimulation. So we would go ahead and do this. That's how I assess it anyway. And if it's not really responding, you're going to give it a 1. All right, let's go to the A. The A is for activity. Well, look at your baby. What is it doing? Are the legs and arms totally flexed? If it is, you're going to give it a 1. And if it's moving all around, you're going to give it a 2. And if it's not moving at all, again, this is more critical. By here, we have people helping us. Okay. R is for respirations. Is the baby crying? If it's crying, it's breathing. All right, so you don't necessarily have to go in and count respirations when you're doing this because this is not your, quote, newborn nursing assessment. This is just the APGAR assessment, all right? So what you're going to do is you're going to add the points together and you're going to assign it a number. So let's say I'm going to switch colors here. Let's do red. So let's say at 1 minute, our baby was acrocyanotic, but the heart rate was over 100. It was moving around when we suction its mouth out. It's moving its arms and legs, and it's crying. I'm hoping you can do the math, and you will say that as 2, 4, 6, 8, and 9. So our first APGAR is 9. That's 1 minute. At 5 minutes, you're going to do the same thing again, okay? So you're going to do the same assessment again. And if at 5 minutes we are still acrocyanotic, but all of these are still the same, what's your answer going to be? 9. So your 5 minute APGAR is 9, and how you write that is 9 and 9. So all you're doing is evaluating all of these things at 1 minute and at 5 minutes. Okay? Now down here you can see, so what, right? I keep telling you guys there has to be a reason. What's your rationale for what you're doing? Down here you can see this tells you how your baby's doing. So if our APGARs are 9 and 9, this tells us this baby is doing just fine. Sometimes your APGARs will, you can think of all kinds of number situations. 7 and 8, 5 and 9, right? So what you're going to want to do, again, if you guys are the newborn nurse and you are assigning an APGAR, it is your responsibility to tell the labor nurse when you hand off the baby, once it's stable, you're going to say, I gave the baby APGARs of whatever you gave, and tell them what you took points off. For example, let's say, I'm going to switch colors again. Let's say it's 1 minute and your baby has acrocyanosis, the heart rate's over 100, but it's not really grimacing and it's not really active, but it's crying. So what's our 1 minute? 2, 4, 5, 6, 7. Our 1 minute is 7. Oops, I think that's off the screen. Our 1 minute is 7. And now we go ahead and we do it 5 minutes later, sorry, and we still have acrocyanosis. Our heart rate's still over 100, and the baby now is responding to stimulation. So put that little check here. We're not really an active baby here, but it's crying. So now what is our APGAR? 2, 4, 6, 7, 8, 9. Did I add that math right? 2, 4, 6, 7, yeah. So our APGARs are 7 and 9. So you're going to make sure that you want to tell and report why you took things off. Okay, so why you took points off for this baby. So what happens in the real world here, right? So again, you're the newborn nurse and I'm the labor nurse. We have two teams. The baby gets delivered. The baby, if it's stable, goes with its mom, and you're drying it off and assessing the heart rate, and you're doing your APGARs. Once the baby is stable, as far as you're concerned, which means that your APGARs are normal, if you will, the vitals are normal, your assessment is normal, it is clear that the baby is transitioning to being out of its mom, you're good to go. And then when your labor partner, your labor nurse, tells you as well, their client is stable. We don't have history. We don't have any postpartum hemorrhaging happening. The vitals are stable. What you're going to do as the newborn nurse is hand off this newborn to the labor nurse. And now the labor nurse, for the remainder of the recovery period, is in charge of that couplet. And then that labor nurse will transfer the baby over to postpartum. Okay, when the client goes up. So again, part of your handoff is going to be what the APGARs are and what you took off points for. All right, so something else that gets done, and this is the immediately following delivery, in that immediate period, if you will, right? Because we're establishing safety first. So you've gotten your vitals, you know the baby's breathing and its heart rate is normal. You've done your APGARs. Okay, we've done all of that. The next thing we're going to do is we're going to band the newborn and its parents. So a couple things about bands, and then I'm going to roll it out to you what it looks like when you're actually in clinical. And by now, some of you might have seen this, and if not, you'll see it at some point. So newborn identification. It is important that we as nurses apply newborn identification upon delivery, in that delivery period, if you will, to both the parents and the newborn. We are responsible for identifying the newborn to the delivering person, the last name, the gender of the baby, and the parent's last name, and their medical records. So, and this information is going to be on the bands here. Now, again, my disclaimer is that you might see hospitals that do a little bit different. This is a general idea of how it's going to work, and this is what your book says too, so we're going to go for. Typically, you're going to place the ID bracelet on the baby's ankle and the other one on its wrist. It doesn't matter which one. But babies should have 2 identification tags at all time. Most hospitals have an infant security system, and that oftentimes will go on the other ankle, opposite the ID band. Well, when are you going to check bands? You check bands anytime the newborn is given to its parents, i.e. upon delivery. If it goes to the nursery for some reason, and then it gets brought back to his parents. In a shift change, both nurses should go in and do an ID band upon any kind of handoff as well. Most of your bands are going to be computer bands like this, which is really nice. It has the barcode scanner, so when you give newborn meds or meds and peds, are just like, babies are just small adults, right? So anytime you're going to give meds to anybody, whether it's a baby, a toddler, a kid, an adult, it doesn't matter. You always are going to scan. And the beauty of having computerized meds computerized bands like you see here is that you can scan them. These bands here are the bands that we used to use before we had computers. We used to manually write the information. That was problematic for lots of reasons. First, what if your writing is very messy? That's one problem. What if you write very big like I do and your writing doesn't fit on there? So there's no barcode scanner with these bands. So most hospitals now will use these bands here as downtime bands. If the computers are down, we're not going to leave a baby unbanded because the computers are down. We're going to band them with these bands here and then switch them out when the computers come back up. All right, so what does this mean to you besides just words on a slide, right? And you're going to see this done when you're in this clinical rotation. So back to our scenario we had 2 slides ago, but this happens also in the C-section room. Babies are banded regardless of where they're born. If they're born in the parking lot, they stay with their parents until they get brought in, and we band them as soon as they get here, right? So babies are always banded. All right, baby is delivered. Certain hospitals the admission process is different, so I'm not going to go over that with you, but baby gets admitted somehow, and then bands are brought into the room. Each hospital is going to have a different way they present bands, but it doesn't really matter for this conversation. On these band sheet, you're going to have 2 tiny bands and 2 adult-sized bands. By process of elimination, the 2 tiny bands are the baby bands, and the 2 adult-sized bands are for the parents. So remember, I'm the labor nurse, and you're the newborn nurse in the same scenario, right? So we're going to get the bands, and it can be in different order, but the bands have to be checked with both nurses in the room. So the 2 of us would come together, and we would verify that the number on the band, I'm circling in this example here, you want to make sure that all the numbers match on all 4 bands, right? So if the number is 00052, as it is in this picture, that number needs to be the same on all 4 bands. Check. Now we're going to verify what it says up here. The last name, the gender of the baby, the parent's last name, first name, medical record, date and time of birth. So we're verifying all of those things, okay? And then we both, as nurses, say, okay, everything's correct. And then one of us is going to take this band sheet and we're going to show it to the client who just delivered to make sure that that client is agreeable and to their partner who's in the room. Once everybody says, yes, that's me, that's the right information, we can band people. A couple of things I think you should know. First and foremost, it is not uncommon, actually, for the delivering person and the partner to have different last names. We need to know, because we need to make sure we tell our clients that the baby is going to have the delivering person's last name. So if that conversation hasn't been had, we should just tell them. What do you think the reason is for that? The reason is that the baby needs to always match its mom. And then whatever they name the baby once the baby goes home is up to them. But while the baby's in the hospital, the 2 of them will always match. All right, that's the first thing I wanted to tell you. The second thing I wanted to tell you is that what if your delivering client is all by themselves and they have no family? You might see some nurses who put the other band in the chart because someone's coming soon. You might see some nurses like me who don't take any chances, and I shred that band. It depends, but what you should understand, and at that point you would follow the policy of the hospital, right? But what you should understand is that anybody who has that band can say that that's my baby. So we want to make sure that if that band is not being shredded and then printed up later when the partner gets there, we want to make sure that that band's not going to get left behind or fall to where somebody else who shouldn't have it might get a hold of it. So then you're going to band everybody, and then that's done. And then let's say at the end of the recovery, the labor nurse is going to transfer the baby and the family, the couplet, up to or over to postpartum. So just like you do in Farm Lab when you're giving meds to an adult, you don't want to say, is your name Jennifer Dahl? They're just going to say, yes, that's my name. So again, you're going to ask everybody to pull their bands out, and you, as the nurse, can be in charge of the baby's bands. So what I do is I ask one of the parents, okay, read me the band number. And then they have to read it to me, and I'm the one that verifies that it's right. Okay? Because again, it just makes sure that everything matches. If something doesn't match, we got a problem. We got to make sure why. Okay? But most of the time it matches. If we're doing our due diligence as nurses, most of the time it matches. What if one of these bands fall off? That might happen. You might be in doing your newborn assessment, and you see the ID band in the bassinet. It is best practice, and again, I would default to what your policy is, but it is best practice to print new bands and identify the baby that way. All right, that's it for this slide. All right, so as we've talked about over and over again, and again, you've heard about this since you were in the very beginning of nursing school, we need to have our equipment to do our job. You'll have your stethoscope. Now, some hospitals will keep newborn stethoscopes kind of at the warmer, ready for you guys to use. But again, you'll know what your hospital has. So what equipment do we need? A bulb syringe, which we've already talked about. A stethoscope with a pediatric head. If you're going to use your own stethoscope, just turn it around. So using the smaller side. An auxiliary thermometer. So right here, avoid rectal temps as they can injure delicate rectal mucosa. There are some hospitals that I know of who still do rectal temperatures, even though that's not best practice. All right, but you're gonna do what they do, but know that the evidence says we should do axillary temperatures. Okay, a blood pressure cuff to evaluate any cardiac issues. Now, a lot of hospitals don't do blood pressures on babies unless they're in the NICU. All right, so if you are at a hospital that doesn't assess all babies for blood pressures, that's okay. There's going to be some variance for that. You need to have a scale because all babies will get weighed, so we know what their delivery weight was. You also need to have a tape measure. What the tape measure does, it measures the length of the baby, because part of what we're assessing is the length and the weight. All right, so you need to have a tape measure to do that. We're also going to measure the head circumference and the chest circumference and the abdominal circumference. Now, again, I want you to know that there might be some differences to this. Some hospitals might just do only head and chest, and some might do all three. That is okay. You do what your hospital protocol is, but know that this is what the tape measure is for. And I put in here the landmarks. It's when you're going to measure the head circumference, you're going to measure just above the eyebrows. When you're going to measure the chest circumference, you're going to measure at the nipple line. And if you're measuring the abdominal circumference, you're going to measure just above the umbilicus. I want you to look at this picture here. What they did, and typically it's in centimeters, but that, again, that's not true. Typically it's in inches, so that's good to know. But again, they might want both. You just turn over the tape measure because one is in inches and one is in centimeters. You can be adaptable, right? We're nurses, we're adaptable. When you're going to do any kind of measurements, how you do that is you're going to lift up the baby's head and put the tape measure on the warmer or wherever you're doing it at, and then put the baby's head down and bring the tape measure around the baby's head like we're doing here. Okay, that's how you're going to do that. Finally, you're going to need clean gloves. Babies have not been bathed yet. A baby that has not been bathed is technically not really clean because it has all the goobers and mucus from delivery on it. All right, so wear gloves. Once you've bathed the baby, and you know it, or once it has been bathed, you don't have to wear gloves to touch your newborn. You have to be very obvious that you're washing your hands. So that's the idea with gloves versus clean hands. But always I want you to wear gloves until the baby is bathed. So a couple of things I want to kind of point out about a newborn assessment. Just like you assess adults or pediatric patients, our job as nurses is to do assessments. I've talked to you about it over the weeks and how important your assessment is and how your assessment activates interventions if needed, right? The newborn, quote, admission assessment, if you were going to use quotes here, the admission assessment is done when it's born. All right, so if in this scenario, if you are the newborn that's at the delivery and I'm the labor nurse that's at the delivery, you are doing a newborn admission assessment along with the APGARs and the vitals and the weight and the length. You're doing all of that, okay? So your initial newborn assessment, we can also call it an admission assessment. It's the same difference. And I just kind of wrote a couple things, but we're going to go through all of the head to toe assessment just like we would on an adult. Here are your norms. These came out of your book. I will not be asking you norms on your test. To me, that's not any kind of application of nursing, but I want you to know it's important for you as a nurse in this rotation, as well as in your peds rotation, what your normals are, okay? And they're here. All right, this slide and the next slide, I kind of separated it into two individual slides like this because it was easier for me to demonstrate what it is. This is called a newborn gestational age assessment. Sometimes it's called a Ballard. Okay, so this is another name for it. Older nurses older than me might call it a Dubowitz. That's a really old name. So if you hear that, that's what they're talking about. But honestly, these are the two most common names that you're going to hear this called. What you're evaluating here is the gestational age actually based on the newborn. Now remember, in week 1, we talked about evaluating gestational age based on the pregnant client's last menstrual period or ultrasound, okay? And that's what we use to determine the due date. We've talked about that. Here, you're actually looking at your baby and doing the gestational age assessment based on the actual baby. Ideally, they're close, okay? Before I begin, you might ask yourself, well, what if they're not? What if my gestational age by my due dates, my last menstrual period, is 36 weeks? But what if the score of my gestational age assessment is 39 weeks? Are you going to do anything about it? Nope. What you're going to do as a nurse is say, well, that's interesting, and understand that maybe the person either scored it, maybe they made some mistakes, so you might want to do it yourself. But if in fact there's a discrepancy between the due date, for example, the gestational age based on the last menstrual period, or the gestational age here on your assessment, that's okay. You might want to note it. It's just more information for your toolbox of knowledge. I wouldn't tell your patient because you're just going to stress them out because they're going to ask why and you're going to say, I don't know. You might tell the pediatrician when they round, just kind of as an interesting fact, but you're not going to change your care based on that. It's just more of an information tool for us as nurses to have. All right, let's go over this first part here. All right, so personally, I typically do my gestational age assessment when I do my admission assessment. So you might see your nurses kind of doing it, mixing everything all at the same time. I would like you guys to do this with your faculty the first time, under the warmer with the heater on for the baby, because you're new, and when we're new, we're slower at things, and that is okay. But I want to make sure you know how to do it. So if your nurse is kind of blowing through this assessment and you're like, but wait, you're still stuck on the first one, that's okay. Let them do what they need to do, and then you grab your faculty and text them and say, hey, Professor so-and-so, would you come do this Ballard with me? They will come do the Ballard with you, okay? So that's kind of how I want you to handle it. Anywho, let's go through this. All right, the first thing you're going to assess is the posture. All you're doing at this point is looking at the baby. And you're just going to kind of check mark where the baby is at. All right, so what I want you to notice here is things that are on this left side, on my left, these are our earlier babies, and over here are our mature babies, our post-mature babies, and your baby's going to fall along anywhere along this line here, okay? So I want you to look at your baby, and I want you to say, oh, this baby's lying, and don't touch it, just leave it alone for a second, and I want you to circle or check mark or somehow give a score. So if my baby is lying like this, I'm going to assign it a 3. Okay, the next one, what you're going to do is you're going to pick up the wrist and you're going to try to see how close you can get the fingertips to the arm. And what does the gap look like? Is it a really big gap? Because we're measuring this little guy in here, this gap. So your really early babies, they really can't get their fingertips close by their arm or the inside of their wrist. But your term babies can. So I want you to figure out where your baby is, and let's say your baby is here. So we're going to give it a 3. Your arm recoil, all you're going to do right now is you're going to stand at the foot of the bed, so your baby's feet are facing your tummy, I want you to grab on to the baby's hands, and that's also when you can assess the grasp reflex. We're going to talk about that in a couple of slides. The baby's going to grab onto your hands, and I want you to straighten the baby's arms by its side. Then I want you to let go, and you're going to evaluate where the arms wind up. On your really early babies, you're going to let go of the hands, and the arms are going to stay extended. And there's going to be this big gap, this big extension here. And you'll see as the babies get older, here's your term baby. When you let go, it's going to bend its elbows, and the hands are going to be up by the shoulders. All right, so let's say our baby is here. That's a 4. Popliteal angle, to be honest with you, I assess these two together, the popliteal angle and the heel to ear, because it's almost the same movement. You can go down this score, down this sheet as it says here. So popliteal angle, again, you're seeing how, it's kind of like what we're doing is we're assessing how far the baby can naturally extend its leg. So baby, and again, you're facing the baby's feet. The baby's feet are at your tummy. And I want you to put the baby's thigh, so the femur bone, up against as far as you can. So it's not going to lay flat. Like in these pictures, it looks like it's laying flat. But you're going to go ahead and push the baby's leg up. And I want you to see what the baby does with the lower part of its leg. On your pretermers, if you were to push the baby's femur against its belly, the foot is going to almost point towards its head. And you can see the older it gets, okay, this gap that's behind this popliteal angle, this gap here is going to get smaller and smaller, okay? So here, we're going to say this baby is here. The scarf sign, you're also measuring the gap. It's kind of hard to see here, but if you were to kind of zoom in on this slide, you're measuring what you're measuring is the angle of the arm across the baby's chest in relationship to the sternum, all right? So again, here's our new baby, a really early baby. You can get that arm completely across its chest and the elbows on the other side of the chest. But look at this is our really term baby, and you can't do that at all right? So let's give this baby a 4. All right, so finally here, our heel to ear. So what you're going to do is baby's still on its back. You're going to you're going to take a hold of the upper part of the leg, and you're going to gently, we're not like throwing anybody's leg back here. We're going to gently push the heel of the foot back and see how close we can get the foot to the ear. That's what it's called, a heel to ear. On your preterm babies, you can see it goes all the way up. But here on your term babies, you really can't get it very far. So let's give this one a 3. All right, so this is 6, 10, 14, 18, 21. So our total here is 21. All right, let's go to the next slide. So remember, our previous slide, we had 21. All right, so now we're going to look at, mostly going to look at the baby's skin. Let's start here. Let's start with the first one. Remembering that this over here on my left are the really early babies. I mean, look down here, the lids are fused, so these are really early babies. And these babies over here are the mature babies. So let's look at the skin. And I want you to find the one that matches your baby. What I want you to notice here is that the older the baby is, it is not uncommon for you to see cracked, wrinkled skin. This baby's been floating in fluid for 40, 42, 41 weeks, so it is not uncommon to see the older babies have this deep, leathery, cracked skin. So let's assume that our baby is here, so we're going to give it a 4. All right, so let's go to the next line. So lanugo is baby hair. It's that really fine, fine hair. Some babies are born with a lot and some are not. The funny thing about this is that the earlier babies have none, and you'll see it starts growing and then it thins and then it keeps thinning and keeps thinning. So it can be kind of confusing, and I can appreciate that. But let's go ahead and look at our baby and see if we see any. It's super fine baby hair, and we're going to see that we've got some bald areas. So we got that. the plantar surface, and again, you can mix this with your assessment or not. I want you to look at the baby's feet, the soles of the feet. The older the baby, the more creases they have. So this baby is, we're going to say it's a term baby, we're going to give it a 4. Okay, so I don't want anybody busting out a tape measure here to measure this, all right? But I want you to, but I think that you guys, all of us as nurses, none of us have a tape measure to measure it. We just look at it and see that if the areola is very, very small, if it's flat, or if it's full. So assign what's there. Are your eyes open, or are they fused like this teeny baby here? But if the baby can open its eyes, and then you're going to assess the ears. Your ear cartilage feels just like yours, except it's on a baby, so it's smaller. So I want you to grab onto your ear right now as you're listening and pull your ear forward and then let go and see how it bounces back and your ear cartilage is stiff. Same thing on a baby. So let's go ahead and let's assign it here. Finally, we're going to assess the genitalia. So depending on what kind of baby you have, I want you to assess it. So the older the baby on a little boy, your testes are going to have descended. And how you would assess that is that you're going to use your pointer finger on one of your hands. Your other hand, you're going to very gently squeeze the scrotum, and you're going to feel if the testes have descended. They're like teeny tiny little peas. Don't squeeze hard. You don't need to squeeze hard. And also you're going to assess the rugae on the scrotum and assign it a number. So we're going to assign it with that. And next on the little girl, if you've got a little girl, I want you to look at the labia majora and the labia minora. And again, see what's covered and what's not, and we're going to assign it. Next, we're going to add everything up. 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Let's go with the boy, because actually we only have one baby here. So now we do 21 plus 20 is 41. So our answer is 41. Well, that means that by your assessment, your baby's 41 weeks gestation. And again, what if by the last menstrual period, it doesn't align? That's okay. You don't have to stress out. Don't tell the parents. Just maybe tell the pediatrician and see what they say. Okay, we're going to start with the head, right? Just like you do on adult, you start with the head and go to the toe. And that's what we're doing here. So as you know, I'm not reading slides to you, but these are the things that you should notice. I mean, I want you to palpate the fontanelles. We talk about that. You know your anterior fontanelle is bigger than your posterior fontanelle. You know that it's diamond shaped. We covered this in week 1. Ideally, both of your fontanelles are flat when your baby's just lying there. Please expect that if the baby's screaming mad, there might be some bulging there, but there shouldn't be bulging when the baby's lying at rest. You should feel, if you're palpating the sutures, we talked about sutures in week 1, I want you to palpate your sutures. There might be a little bit of a gap, okay? There should be a little bit of a gap, I should say, and sometimes they might be overlapping or called overriding, and we talk about that in the next slide. So when sutures are overriding or there's a gap, when sutures are overriding, they're kind of like pushed on top of each other. Why a baby has overriding sutures is because when you're having a vaginal delivery and babies are coming out of a small space, the bones overlap on each other so they can fit out. Now, on some babies, as soon as the baby is out, the bones move back to where they're supposed to be. And on other babies, it takes a couple of days. That's okay. When you're doing your documentation, most hospitals do charting by exception. So within defined limits, WDL, accept. So your overriding sutures would be something that you would make an exception for here. Something else you might see on the baby's head is something called caput. That's this right here. All caput is swelling of the head. It's because it was in a small space. All right. Now, if you see in this picture here, caput can be anywhere. It can override your sutures, like in this cross section here. All right. It goes away. You don't need to do anything about it. When you're doing a vaginal exam on your laboring client, and we talked about station in week 1, when you're measuring station, you're measuring the fetal skull against the correlation to the ischial spines. If your baby has caput, you can feel it when you're doing a vaginal exam. You'll check your client and you're going to run right into this swollen tissue, and it feels just like swollen tissue. But you're going to reach around it and see where the scalp is, all right? Caput is very normal. It goes away within a couple of days, like it says here. Acephalohematoma is different. Acephalohematoma happens most often when a vacuum is used, okay? Now, your book says forceps as well. My argument to that is that forceps, like we talked about in week 1, gets applied to the temples of the baby. So you don't often see cephalohematoma as that trauma from that instrument. You're going to see more of the trauma from that instrument at the temples of the baby. But when you put a vacuum on, remember we passed the vacuum around in class? And when you put the vacuum on, the suction can create this cephalohematoma here. What's different with caput, a couple of things. Caput crosses the suture line and it's just fluid, okay, localized swelling. Acephalohematoma does not cross suture lines, and what's in here is a collection of blood because of the vacuum, okay? Because of this collection of blood, it can lead to physiologic jaundice when that happens. Excuse me. We talk about jaundice in a little bit. This right here is an example of what it looks like on a baby. My daughter, like I told you in week 1, they had used a vacuum to get her delivered, and she had this perfect little suction cup right there at her head, looked just like this baby. Because my girls had no hair when they were born. If you've got a baby that has lots of hair, you might not notice it as much, but that will go away in a couple of weeks. Okay, we've assessed the head. Let's go ahead and assess the eyes and the ears now. So we're going to assess in the eyes. We are going to make sure that they're symmetrical. They typically don't have a color right at birth. It is not uncommon to have some subconjunctival hemorrhages, and again, you might see that, and that's just because of being squished in the mom's pelvic bones and with those muscles there. Sometimes the baby can have random jerky eyeball movements. Sometimes the eyes can appear to be crossed. That's normal, even though it will alarm your parents. But if you see that, just tell them it's because these muscles, the baby's really not had to look at anything before. And so now it has to develop those muscles to keep those eyeballs steady. So that's okay. Lacrimal glands don't typically make tears. So even when the baby is screaming, you might not see tears in the newborn, right in the newborn time here. So we looked at the eyes. Now we're going to look at the ears. Your ears should be even with the eyes. If your ears are low set, it's an indication that the baby might have Down syndrome. All right? Let's just pause. So what if you think the baby has Down syndrome? You're not going to tell the parents the baby has Down syndrome. That's not our job. Our job is to do our assessment and let somebody know. You're going to keep assessing your baby, and again, if you believe that the baby has Down syndrome, you're going to call your pediatrician and let them talk to the family about that, okay? Because they're going to clearly have questions that you can't answer. So be there when the pediatrician rounds, of course, so you can help reinforce the teaching, but it is not up to us as nurses to tell them that we think the baby has Down syndrome. They may know because they've had genetic testing done, but again, we're not going to confirm anything that is not within our scope of practice, okay? We already talked about the ear cartilage. Checking the ear canal for patency. Back when I first started being a newborn nurse, we used to use Q-tips, and that's how we would assess it. We're not doing that anymore. Don't put anything in the ear canals. That's what the evidence says not to do. We don't want to do that. Just peek inside there, okay? It is not uncommon for there to be skin tags on the ears, especially at the tragus part of the ear. Just show the parents so they know, and note it within your assessment. Not a big deal. The newborn should be able to hear. We do a hearing assessment at most hospitals nowadays upon discharge, but if they hear something, they often will turn towards the noise. But again, we do a hearing assessment before they go home. All right, we've assessed the eyes, we've assessed the ears. Let's talk about the nose. So the nose should be just like your nose in the middle. Remember, babies are just small people. Something you should know, that newborns are mostly nose breathers in the very beginning for the first couple weeks. They don't become mouth breathers until they get to be about 3 weeks old. They don't know that if their nose is occluded, they should pick up their head or turn their head so they can make sure they're breathing. So be mindful of this. If the baby is breastfeeding and the client has large breasts, we want to make sure that we support that nursing client to watch for clues that the baby's nose is blocked. Get the lactation nurse involved. They have all kinds of tricks, like I've already told you. They're amazing people. All right, we've assessed the eyes, the ears, the nose, and let's look at the mouth. We're just going down the baby, right, doing this. And again, I want you to do this when you're in clinicals, but you might need to do it with your faculty because you're going to be slow in the beginning. And again, that is really okay. You're going to assess for the intactness of the palate. Well, how you do that is you're going to put a glove on, and you're going to put your pinky, turn your hand upside down, and you're going to take your pinky and you're going to put it in the baby's mouth. So that your fingernail is against the baby's tongue, right? And I want you to rub the top of your pinky on the palate and make sure it's all intact. The baby will almost 100% of the time start sucking on your finger at that point, which is super cute. But it also, besides being cute, it's also a way that you're going to assess the reflex of the suck reflex when we get to that point. So you can kind of knock 2 birds out with 1 stone. Go ahead and take your finger out of the baby's mouth, and you should just look at the baby at this point. You should see that the lip movements should be symmetrical. The tongue should not just stick out all the time. A protruding tongue is also a sign of Down syndrome, so if that's the case, just note it. But again, we're not going to report that to the client right away. Baby shouldn't have tons of saliva. I actually should move this up here because I want you, when you're assessing the palate, I also want you on your way out of the baby's mouth to run your finger on the upper and lower jaw inside where your teeth would be. Because sometimes babies are born with things called Epstein pearls. And I put teeth because some docs will call them baby teeth, but they're not teeth like on our mouth right now. They're just these little white lumps. It goes away, but it's something that you would want to document in your nursing assessment. So let's look at the neck. The neck should move freely. Now, the baby it can turn its head from side to side, right? But it can't support the weight of its head, but it should move freely. So if the baby doesn't have any head control at all, like if you pick up the baby by its shoulders or lift it off of the bassinet, the baby, there should be some muscle rigidity to kind of try to lift up the head on the baby's part. It really can't do for very long at this stage, but But if the baby just flops its head back, that's another sign that the baby might have Down syndrome or that it's really early baby. Okay, so looking at the chest, again, it should just look like your chest, right? It's just a regular human chest. You're going to go ahead and you're going to assess for clavicular fracture. I want you to think about week 1. We talked about the difficulties we can have in having a vaginal delivery. Certainly if there has been a difficulty in your delivery, that's something you want to note. By now, you'll have already done your Ballard on your baby most often, and you will see the baby lying on the bassinet. If the baby should move all 4 of its extremities, but if you notice that it's not moving one of its arm, you might suspect that there's a broken clavicle. How you assess for that is you're going to take your pointer and your middle finger, and you're going to put a little bit of pressure on the clavicle. If it's broken, the baby will probably cry, so don't put too much pressure, but it feels like crepitus, okay? Again, you're not going to tell the parents you think the baby's clavicle is broken. You're going to write it down. You're going to document that you felt it, and you're going to report that to the pediatrician, and then they can order an x-ray and talk to the parents with the results of that. You also want to assess for breathing. Your baby should breathe just like you. There should be no noise when it breathes. There should be no retracting of tissue between the clavicles or at the sternum. There shouldn't be any of that. If there is, let somebody know. And you already know about the umbilical arteries and the vein. And your bowel sounds, you make sure that you're doing a bowel assessment as well on your baby. Okay, we already talked about range of motion. Your babies should be able to move all of their parts. Again, they're just small people, especially if it is a term baby. It should be able to move all of its parts. It's been moving inside of its mom this whole time, okay? The extremities should be flexed. When you put the baby on its tummy to assess the gluteal folds, I want you to turn the baby over. Make sure you turn its head to the side so it can breathe. And you should look at the gluteal folds. They should line up. Okay, the creases on the back of the legs should be the same on both legs. The soles of the feet should be well aligned, and there should be creases, at least on your term babies, right? This is subject to gestational age, but we just talked about that. On your pretermers, you're going to have less creases, and on your terms, you're going to have more. I want you to assess cap refill. You know how to do that. It's just a small nail bed now instead of an adult nail bed. There shouldn't be any, babies should have 10 fingers and 10 toes. Sometimes there can be an extra digit. What it doesn't most often look like a fully formed finger. It's more like a little nubbin most of the time, and it's usually to the right at this little bone here, to the right of the pinky. It's hereditary, so if you see it, just show the parents, hey, look at this, and we'll let the pediatrician know. They might say, oh yeah, my grandpa had that, or my aunt had that, okay? So they oftentimes will do some kind of surgery on the baby. That's kind of out of my scope of practice. But it's done once the baby goes home. So I don't really know when it's done, but it's typically done after they leave me in the hospital. When the baby is on its tummy and you're assessing the gluteal folds, you're also going to assess the spine. I want you to take your pointer finger and I want you to put it up at the nape of the baby's neck, and I want you to trace the spine all the way down into the sacrum. It should be straight. It should be midline. There should be no openings. If there are openings, we're concerned about, that's concerning for us. All right? Spina bifida and those kinds of things. The anus should be present and patent. Again, I just want you to open the cheeks of the butt and see that it's there. When you're changing the diaper and the baby starts pooping, then you'll know that it's patent 100%, right? And this tells you when that should happen and when urine should pass as well. What I didn't cover is the pink discharge. If your client is breastfeeding, you might notice that there's pink discharge in the diaper. That sometimes will freak your parents out. Some people misinterpret that as a period. That is not what it is. What's happening is when the client's breastfeeding, the hormones will make this discharge happen, and that's what causes that. Don't panic. Just educate your parents and tell them it's fine, okay? We talked about the testes already. We talked about the rugae on the scrotum, and the urinary meatus should be at the penile tip. That's normal. So overall, your skin should be a nice red color, because remember, the baby is breathing and crying and the heart is pumping blood, so it should look just like your skin. Maybe some acrocyanosis as well. Jaundice should not be present at birth, and we talk about jaundice in a little bit here. You know how to assess skin turgor. Okay, we talked about cracks in the hands and feet. Vernix caseosa, we didn't really talk about that. Vernix caseosa is normal. It's the white, it kind of looks like white cream cheese, maybe. And what it does, the purpose of vernix is to protect the baby's skin while it's floating in the amniotic fluid. The older the baby, the less they'll have. Sometimes when a client's membranes rupture, we can see some vernix that comes out as well. It just looks like little fragments. It looks like little, like I said, white cream cheese. That's okay. You just note that. Again, all these things you just note. It used to be when I first started nursing, it was really important to us at that time to get all the vernix off. We don't do that anymore. We leave it in place. Where it typically gathers is in the creases, so like the creases of the legs and the elbows. Just leave it there. And we already talked about lanugo. Wrapping up our skin assessment here, let's start with dermal melanocytosis. I'll be honest with you, we just started calling it that, and there are some hospitals that still call them Mongolian spots. Just use the verbiage that your hospital uses so we don't confuse the clients, okay? But all it really is a dark spot like this that's on the sacrum. It can be on the upper back, and it might be on the shoulders. It's more common in dark-skinned babies, and you'll find that when you point this out, anything you find that is, quote, not really abnormal, that's differing from normal. I like that better. You want to show your parents because it's their baby, and we want to make sure they know what's happening with their baby. The next thing here is milia, and that's right here on this baby's nose. They look like little baby acne, little pimples. There are people that are obsessed with popping pimples. If you're one of those people, that's just fine. But you want to make sure that you tell your patients, don't pop these. They go away all by themselves, so don't squeeze them. The next thing I want to talk about here is a newborn rash. This is actually my daughter, who's now 25, who doesn't have a newborn rash anymore. It's temporary. It goes away in a couple of weeks. It's just because the skin's getting used to being out in the air. Stork bites is this next one here, and you'll see stork bites are pink little splotches that are found most often under the baby's eyes here, between the baby's eyes, and sometimes on the nape of the neck. And they go away by the time the baby's a couple years old. What doesn't go away is something called a port wine stain. It's not that common, but you'll see that when it's different because the stork bites are a lighter pink. Your port wine stain honestly looks like red wine, and it usually covers a portion of the face, and it doesn't go away. So next we're going to talk about newborn reflexes. And again, a lot of this can be combined at the same time. Ideally, we're combining our assessments so the baby is with its parents most of the time and not with us, so we can get our work done. The first one is the sucking reflex, the rooting reflex. And this is one that I told you we could do when you're assessing the palate of the baby, that the baby will suck on your finger as you're doing that. What this is that whenever the baby feels something stroking its cheek, it's going to turn towards that, whatever it is, that direction, and try to start eating. Okay, so this is a sign that we can do to use when we're looking at our baby's looking like it's getting ready to eat. Babies who are lying in their bassinet or in their bed, you don't want to wait until they're screaming till you feed them. Watch for signs that they're getting hungry. They start rooting, they start turning their head, trying to find food. That's what this reflex is. The next reflex, the palmar grasp, and I said that we could assess that as we are when you're assessing your capillary refill and the tone of the baby's neck. When you put something in your baby newborn's hand, it should grab onto your finger. So that's that one. The plantar reflex, when you touch the sole of the baby's foot, all of the toes curl downward. I usually assess the plantar reflex and the Babinski reflex at the same time. On the plantar, all the toes curl down. On the Babinski, when you do that, the big toe comes back and the other toes curl down. So I tried to group my assessments together. The next one, the startle reflex or the Moro reflex. I usually will do this as I'm assessing. I go down and I assess for my clavicle fracture. I'm going down the baby's arms. I'm assessing the skin temperature, the skin trigger. I go down to the baby's hands. I assess the capillary refill. I put my finger in the baby's hands and it grabs onto my fingers. That will assess the grasp reflex. And then what you're going to do is you're going to lift up the baby's arms just a little bit, enough to where the back of the baby is off the bassinet just a tiny bit, and then let go really quickly. No one's being dropped, so don't panic. But when you let go of the baby's arms, it kind of startles itself. That's why it's called that. It opens its arms really big and kind of makes a circle above its head. That's the startle reflex. I will say that if there's any question that you have a broken clavicle, we don't want to do this, obviously, right? So just assess for that first, which is why I told you I did that. The tonic neck reflex is just what it says there. When the newborn extends that one side, the arm and the leg, they look towards that side and the opposite side is flexed. And the stepping reflex is done when you pick up the baby and you kind of hold it under its arms and supporting its neck. When it just hovering above the bassinet or the crib, when its feet, when it stretches its legs out and it's the bottoms of his feet come in contact with a surface, it picks his foot up really quick. So this looks like it's walking or stepping, or is also called the dance reflex. So your newborn can see. Typically when it's born, it can focus on things about 8 to 12 inches away from its face. And if you look, that's the distance from when somebody holds it, so it can really kind of see that person's face. It doesn't see colors right away, so it typically sees in black and white. They prefer dim lights. Remember, the baby's been in a uterus for 9 months where there's no light, so they're used to that. They prefer dim lights. They can hear. They'll turn towards sound of this if they hear something, or if somebody drops something, it might scare them. And again, I talked about how we do hearing screens before they go home. Babies do feel pain. You will see that if a baby is getting circumcised, oftentimes they will give the baby either on a pacifier or on your finger, on a gloved finger. You can put this, it's called Sweeties. It's just this sweet syrup, and that will soothe them and help them to where they don't feel as much pain. So now we're going to talk about the ways the baby can lose its heat, all right? Because it's never really had to do that before. It's been floating in this water this whole time, and now the baby's born and it has to learn how to eat and breathe and maintain its temperature. And all those things which should come natural sometimes don't. A couple of things before we go into ways the baby can lose its heat. So babies are, we don't want them to get cold. Because when they're cold, it's otherwise known as cold stressed. When they're cold, it increases its oxygen demands. And then when babies are experiencing cold stress, they use up their brown fat reserves. So, and brown fat doesn't replenish itself. We want to make sure the baby's not getting cold because we don't want it to use its brown fat up. Brown fat is activated when the baby's cold. I already said that. What it does is when this is activated, it actually helps to maintain the baby's temperature and protect it from hypothermia, okay? We as nurses need to monitor the baby's temperature closely. We do it, of course, when it's born, right? It's going to be done pretty often. We're going to do it before the bath and after the bath, and at least a couple times during our 12-hour shift, knowing that it's risky for the baby to be able to drop its temperature too much. So we got to make sure we're monitoring it. Like I said, we do axillary temperatures. Babies who are experiencing who are experiencing hypothermia, this is kind of what you can see. Babies who are hypothermic. Our goal is to maintain our temp here. Now, this again came out of your book. Your hospital where you're doing clinicals at might have a different goal set for the baby, but this is what the literature said is the goal for us to maintain these babies' temperatures. Babies lose heat 4 different ways: by radiation, convection, evaporation, and conduction. One of the ways your baby can lose heat is by conduction. Conduction happens when there's a loss of body heat, when the baby comes directly in contact with cold surfaces. So you want to make sure that you preheat your warmers. You'll see that's part of your job if you're going to be the admitting nurse of a baby, is to preheat your warmers. Ideally, you want to preheat everything that's going to come in contact with the baby so we don't have it lose its heat through conduction. Skin-to-skin contact with anybody. When you do skin-to-skin contact, baby should just be in its diaper. No blankets, no t-shirts. And then you just put the baby directly against somebody who's warm skin. Whether it's a parent, a grandparent, a sibling, it doesn't really matter. But skin-to-skin contact helps reduce the chance of this baby losing its heat through conduction. Another way a baby can lose its heat is by convection. And just what it says here. We want to make sure that we don't have cold air blowing over the baby. So I don't know if people still use fans in labor, but people in labor can get pretty hot. And so they may have fans in their room. We want to make sure that the cold air is not blowing over the baby, okay? We want to keep that room nice and warm for the baby as well. Another way a baby can lose its heat is through evaporation, and this can happen when the baby is born, remember, because it's coming out of wet environment out into the air, and so it can lose its heat via evaporation at that time, which is why when the baby's delivered, we put it on warm blankets and then dry it off. As soon as those blankets become wet, please get rid of them and get new warm blankets. Also, when you're bathing the baby, it's important that when you bathe or when the parents bathe, that you're only going to expose one part of the body at a time, because again, a wet baby can lead this child to lose its heat through evaporation. And finally, radiation. Radiation is a way that babies lose heat when from their body when they come in contact, not direct contact, but they're close to a colder surface. For example, if the incubator walls, if the baby's in an incubator and the plastic walls of that incubator are cold, just the act of the baby being close by those walls can cause the baby to lose heat through radiation. We're going to spend a little bit of time talking about newborn complications. Now, there's just tons and tons of stuff in your book about newborn complications. I will say I don't cover all of it anymore. A lot of things we've talked about already. We've talked about birth injuries, but we talk about other things. In your PEDS class. These here are the things that we're going to cover in class today. First, we're going to talk about hypoglycemia. You know what hypoglycemia is. You've been around a while. It's different. The parameters are a little different for babies. So the normal glucose of a term healthy newborn is between 40 and 60, like it says here. Just like with an adult, if we have untreated hypoglycemia, there can be catastrophic problems that happen. Right here, we talk about the risk factors that would put the baby at risk to becoming hypoglycemic. And you're going to see as we talk about these for the next little bit, hypoglycemia, poor feeding, and hypothermia are very closely related and very closely linked. Risk factors for newborn hypoglycemia: if our client is a diabetic, if the baby is premature, if the baby is large for gestational age or small for gestational age, that puts the baby at risk to having issues with its blood sugar. Or if there's stress during the time of delivery, that also can put the baby at risk. Now, we've talked about delivery issues and difficult deliveries, so I will refer you back to week 1 so you're aware of the things that can make it risky for our baby at getting hypoglycemic. So what's your assessment? These are the things that you're going to see. Baby's going to be jittery, and it depends on how low the sugar is. Sometimes if it's not too low, just maybe like the fingertips will kind of bounce around, but the lower the sugar, the more pronounced the jitteriness. Sometimes you can even have like the whole arm is jittery. So if you're seeing the baby being jittery, let's go ahead and check its sugar. If the baby is not eating well, let's check a sugar as well. Again, I told you that these are all linked together. Baby that can't maintain its temperature, we want to check its sugar as well. Or the crying on a newborn is kind of sad and weak, let's check its sugar as well. Each hospital has its own protocol. All I want you guys to know is that if you know your risks, what's your assessment going to be, and what are you going to do about it? You're going to check a sugar, and you're going to follow the algorithm and the protocol that is outlined at your hospital. Next, we're going to talk about respiratory distress syndrome and meconium aspiration. So you guys know what ARDS is, right? It's adult respiratory distress syndrome. So now we're going to talk about newborn. There really isn't an N there, just so you know, but it's the same idea. When a newborn has respiratory distress syndrome, it's because the surfactant is less than it should be, okay? The surfactant's really important because the job of the surfactant is to keep the alveoli from collapsing on itself. And when you've got a collapsed alveoli, we can't have gas exchange happening. So they're all kind of linked together. So who's at risk for developing respiratory distress syndrome? I do think everything here is very self-explanatory, and I know that we talked about this in week 1. Okay, and if you can't remember why this is important,
I want you to go back to your notes in week 1. I'll give you a hint. It has to do with the thoracic squeeze, and that's all I'm going to tell you. Okay? So know who's at risk. This is I want you to put this into your nursing practice no matter where you work. It doesn't matter if you work in the ER or telemetry or psych or wherever you want to work. Know who's at risk for developing complications. Know what the assessment is going to be, and what are you going to do about it? That's nursing. Okay, so you know your risk, and now when you have a baby that's experiencing respiratory distress syndrome, this is what they're going to experience: tachypnea, nasal flaring, grunting and retracting. Grunting, you will probably hear it during clinicals. Just like when you breathe right now, nobody hears you breathing. It's just gas exchange. Air moves through your body, and that's it. You're breathing right now. But babies who are grunting, it's usually expiratory grunting. It's almost like they're holding their breath partially. So the air escapes through the vocal cords and they make a little sound, okay? So that's grunting. Retractions happen. They can be intercostal retractions or sternal retractions. That's fine. Either one are concerning. Cyanosis, you'll find that your baby is cyanotic if it is having respiratory distress syndrome. And then unresponsiveness, obviously. Apnea, that's pretty obvious too. All right, so now you know who's at risk and what you're going to see, and these are the things you're going to do about it. We do talk about meconium aspiration as we get farther in, but I do want to say babies with meconium-stained fluid are born every day. It happens. We've talked about why it happens. Not every baby who is born with meconium-stained fluid will aspirate that meconium. Okay, but again, it's best to be ready and have all of your equipment. You may find that in the hospital you're doing clinicals at, if they know that the baby has meconium stained fluid, like when the membranes rupture, it's not clear, is what I mean. They will have the NICU team come and be on standby for the delivery, because the concern is if baby's been floating in meconium stained fluid for a long time, we don't know how long it's been, right? And it's not breathing yet because it's floating in water. When the baby's delivered and it's been floating in meconium-stained fluid, so the meconium-stained fluid is kind of in the lungs a little bit. When the baby takes that nice big breath and goes to cry, the concern is that nice big breath is going to push the fluid into the alveolar spaces, which can cause this to happen, okay, which can cause collapsing or obstructing of the alveolar spaces, and that can lead to respiratory distress syndrome. Okay, so again, to prevent that, when the baby's head is out but the body is still in, they're going to suction really, really, really well to see if we can get a lot of that fluid out of its body before it takes that big breath and pushes it lower. And I kind of just talked about that here. So what are we going to do? Ideally, if I talked about if there's meconium stained fluid and when you suction, but if your baby's demonstrating the symptoms like we talked about, suction them out, see if we can get some fluid out. Maybe there's some fluid blocking their airway. And we're going to maintain oxygenation, thermoregulation. If it's bad enough and it is a problem with the surfactant, they will give surfactant. These things are not done usually in the well baby nursery. If a baby's having a respiratory distress syndrome, it's more than often not going to be in, whether it's the transitional nursery or the NICU, but it needs closer care. This is a higher acuity patient than your average well baby who's not having any complications. So those of you in the NICU might see this happen, but if you don't go to the NICU, I'm hoping you don't see this happen. Oh, and here I wrote this here. I already told you. But this is the percentage of meconium stained fluid that happens in during delivery or in labor anyway. All right, now we're going to talk about the preterm newborn. These babies are born between 20 weeks and 36 and 6 weeks. We talk about late pretermers a little bit in one of the slides too, but your late pretermers, they're after 34 weeks and before 36 and 6, okay? So there are different little classifications there. So regardless, our pretermers are at risk for all kinds of issues, just because depending on how early they are, and that would make sense to you. You know, your 23-weeker is going to be, or let's say a 27-weeker is going to be at way more of a risk for things happening than your 34-weeker, who is still riskier than a 39-weeker. So the earlier the baby is, the riskier it is and the more complications this baby can have. Oh, I wrote that right there. Okay.
And these are all the things that your preterm infant can experience right here. And a lot of these are covered in your PEDS class, so I don't go over it too much. But as far as the labor nursing goes, which is that's what we're talking about here. So there are certain things that will land your client to deliver preterm. Now, when we talk about the antepartum lecture, we talk about ways to prevent preterm labor and who's at risk for delivering preterm. So we talk about that more as we talk about our antepartum lecture. But for us as labor nurses, we need to know who's at risk, right? All of these things here, the maternal hypertension, here, we talk about that in the antepartum lecture. Multiple pregnancies that are close together. So if somebody wants to have their babies, 10 months apart, that's within their right to do so. But we need to know that that puts them at a higher risk for delivering the kids preterm. The younger the pregnant client is, like if they're teenagers, that really puts them at risk too. There are some things that you're going to talk about more in detail in the antepartum lecture, so I just want you to know that these are the risk factors, but you won't have to understand them until I teach you about them, which is in the antepartum lecture, okay? So here you are. Babies are delivered. So what are you going to see in your delivery? That's besides knowing the gestational age, you'll already know that. But when you're assessing your baby, these are the things that you're more than likely see. Again, it depends on the gestational age. Like I said earlier, if you've got a 26-weeker, it's going to be symptomatic of different things than a baby who's 34 weeks. But these are your findings when you're assessing your baby. Well, like I'm always telling you, it's not enough to just know what it is, but you have to know what to do about it. You're the nurse, right? So what? That's what I always say. You know it, but so what? Okay, well, this is what you're going to do about it. All of your labor nurses, your NICU nurses, we all have advanced life support training for newborns, okay? Your PEDS nurses also have it. So we're ready to resuscitate at any time. But you also need to make sure that you have your equipment, right? If you want to make sure that you have the things you're going to use to resuscitate your baby. You want to make sure that your baby has a gag reflex, okay? Because some babies, it's depending on how early they are, their gag reflex is immature, so they won't be able to eat via a nipple or a breast. They'll have to be tube fed or gavage fed. We always want to make sure that our client, our new little newborn client anyway, is nice and warm. If they're in an incubator, it needs to be a pre-warmed incubator. And if they're under the warmer, again, we want to keep it nice and warm for them. And these are the symptoms of hypothermia. I think we already talked about that on one of the slides. Ideally, you want to keep the baby nice and settled down, decreasing of stimulation, okay, because that helps to conserve body heat. The more the student, sorry, the more the baby is agitated and crying and moving around a lot, the baby's going to use its heat up. So we want to keep it nice and settled down. Ideally, if the baby can tolerate it and if it's stable enough, skin to skin is great because it helps to maintain the body heat on the baby as well. So a little bit about our late pretermers. Like I said earlier, our late pretermers are between 34 and 36 and 6. Okay, so these babies, they're just smaller than our older babies. So oftentimes you're going to find that your late pretermers are not preterm enough to go into the NICU, but they're a little bit early enough to where when they're on the postpartum floor with their parents, they're a higher acuity than your older babies. From a charge nurse perspective for doing staffing, your late pretermers require a lot of nursing hours. So when I used to do staffing in the postpartum unit, if I had late pretermers, I'd spread them out because they require blood sugar checks and they have their own struggles, even though they're not really premature, but they're in this very small window that they have their own struggles trying to adapt to being outside their mom's body. They can have feeding problems. They get really tired, so they really don't want to eat. And the problem is that if they don't eat, their blood sugar will drop and their temperature will drop. So remember, all of these things are linked quite a bit. They can have problems with grunting and retractions, some respiratory distress complications. They can have issues with jaundice, which we're going to talk about in just a little bit here. Okay, so why is this a higher acuity patient? We have to assess them more often because they're not 100% stable. Okay, we assess their vitals more often because we know we can have the issue with hypothermia. We can check, depending on your policy, but all late pretermers have their blood sugars checked a lot. But most of the policies are going to do them AC and 1 hour postprandial, so that's a lot of nursing time too. Okay, our recommendations to our parents is to offer early and frequent feeding. In my experience, the complication, the struggle here with the late pretermers is when your mom really wants to breastfeed. It can be a struggle because these late preterm infants, they don't have a lot of energy. So they don't really have a good latch and they don't really want to take the time to pull on the breast to get the milk out. So it can really take a lot of patience. I'm not saying it doesn't happen, but all of these things, that all the extra work we have to use with breastfeeding, monitoring the sugar, monitoring the vitals, and the extra assessments that we have to do make this baby, who most often is with his parents in the postpartum unit, a higher acuity patient. So these babies don't usually go to the NICU until they're having problems like they can't eat, they can't maintain their temperature or their blood sugar, or they're having a hard time breathing, and then we'll transfer them into the NICU. So we've already talked about the preterm infant and the late preterm infant, and now we're going to talk about the post-term infant. So, and you know about issues with the placenta when you get to be post-term, so I don't have to cover that again. But your post-term infant is a baby that's born after the 42nd completed week of pregnancy. So now we've got an old placenta that was circulating to the baby, okay? And we have an old baby. So it could be that the baby passed its first stool inside because the gut was mature. So now we can have complications with meconium stain fluid as well, all right? So you'll get this in report, the gestational age of the baby. What you're going to find on your post-term babies are something like these issues here. And if you go back to the Ballard score that we talked about earlier, we talk about how the skin is looser on our older babies. They can have peeling and cracked skin, okay? Meconium stained umbilical cord and fingernails can happen anytime there's meconium stained fluid. It just depends on how long the baby was soaking in that fluid. Now, we don't know that. We don't send it to the lab to figure out when the membrane's ruptured. I don't even know if that technology even exists. But the longer the baby's sitting in meconium stained fluid, the more apt they are to have like a green tint on their fingernails. And the umbilical cord, which usually is kind of like a whitish gray color, becomes a green color. So when you see those two things, your inkling is that, oh boy, this baby's been floating in this fluid for quite some time. And again, we have issues with hypoglycemia and cold stress. So what are you going to do about it? Well, the baby is already here and it's already post-term. There's nothing you can really do about it. You're going to be treating the symptoms, right? And trying to avoid issues. So if you know that your baby is a big baby, okay, so you're going to make sure that it feeds often. We don't want to have the blood sugar dropping too low. We want to make sure that we're maintaining the temperature so we don't have cold stress issues. So again, you have to understand what the baby's at risk for because it's old, and then we try to do things to prevent it from happening. Okay, now we're going to talk about our small for gestational age baby, abbreviated as SGA. So again, it's all about knowing your risks, like I keep talking about. That helps us be better nurses. If we know what the risk factors are, we're 10 steps ahead of the game. So these are the people, the individuals who are at risk for delivering an SGA baby. All right, so if your client has these things going on, just be ready for it. When the baby is born, it's already born, so it's going to be born with these things happening. It's going to be small. The umbilical cord's going to be thin. It's going to be more dry. The weight's going to be below 10%. And there's a situation with the sutures, which you see there. And these babies have a bigger risk of these issues. So again, if you know that, you can watch for it, right? So what do? Well, we can't put the baby back inside and make it bigger. So what we can do is support the baby that it's here, be aware of its risks, and try to prevent complications. Next, let's talk about the counterpart to the SGA, which is the LGA, the large for gestational age. And again, just like your SGA babies are already here. So what we're going to do is it's important to know the risk factors. And that just helps you kind of be a better nurse. When this baby's born, on your assessments, you're going to notice it's a big baby. The weight's above the 90th percentile. Plump, full-faced. You certainly can have some birth trauma happen because, again, think about shoulder dystocia, right? The risk of shoulder dystocia is a macrosomic baby, so it kind of goes hand in hand with that, okay? But when you have an LGA baby, again, we can't make it smaller, but we have to be aware of the issues these babies are going to have, like here especially, and then what we're going to do about it, right? We're going to monitor sugar, monitor temps, get it to eat early, and be ready for any kind of birth injuries. So let's talk a little bit about jaundice here. So I went ahead and first and foremost, I wanted to give you the normal bilirubin levels. So normal bili is your indirect is less than 6 and your direct is less than 1.5. So it's good to know that. There are two, the most common jaundice that you're going to see, the most common type of jaundice that you're going to see is physiologic jaundice. This is the most common. It's benign. And the pathologic jaundice is the one that isn't as most common. Pathologic jaundice results because of an underlying disease, right? So there's something else going on that is leading this baby to develop this pathologic jaundice. It appears before 24 hours of age or is persistent after day 14. So let's kind of stop a second, and I want to go back to physiologic. So physiologic jaundice typically happens here, 3 days or so after birth, okay? But pathologic jaundice, look, it happens before 24 hours. So that baby isn't even 24 hours old, and it starts developing jaundice. That's unusual. That should be concerning to you as the nurse to say, this is not the, quote, normal or most common jaundice, okay? So pathologic jaundice is the result of something else going on. And baby's going to start getting yellow before it's 24 hours old, and it's going to persist after 14 days. So again, that's a big difference from physiologic up on top there. Also, when the bilirubin is higher than 25. Okay, so look here's this. That's really high. So when the bilirubin gets really, really high, the baby can develop something called acute bilirubin encephalopathy. All right, and when the bili gets that high, the bilirubin gets deposited on the brain, and because it's there, it can result in all kinds of complications to the baby. Ideally, we're treating it before it gets to that level, okay? And when you have something called kernicterus develop, that means the bilirubin is so high, it is causing irreversible issues, and it's caused by a chronic result of bilirubin toxicity, okay? So a baby that has kernicterus is going to have all of these kinds of signs and symptoms. So who's at risk for developing jaundice? It's important that you know that. Again, you always want to get in front of these things. And you get in front of these things by knowing your risk factors, all right? So when there's a blood incompatibility, which means the baby has an A or a B blood type and the parent has an O, you can have a risk of developing jaundice, okay? Because the baby has decreased liver function because it's brand new, that puts them at risk of developing jaundice. Anytime our mom ingests these meds, we can go ahead and have a risk of jaundice too. When you are assessing your baby, you're going to notice that the skin looks yellow, typically right at the chest, and the sclera and the mucous membranes are yellow as well. Just make sure there's not an underlying cause. Again, make sure that's not caused by something else. And your baby can have some signs of hypoxia and hypothermia and hypoglycemia as well. So what we're going to do is we're going to monitor the bili levels every 4 hours until they're normal. Some hospitals use a serum and some use transcutaneous bili. It is not uncommon for hospitals to screen every baby for jaundice. at about 18 hours old or something. Some hospitals will use, like I said, transcutaneous, and some go straight to serum, Billy. It just depends on where you work. So our baby has jaundice. We have figured it out. We've done our Billy test, and the Billy test says that our baby has jaundice. We're going to call the pediatrician, and they may, if the Billy is high enough, they may give orders to put the baby under phototherapy, otherwise known as Billy lights. You can have single phototherapy, double phototherapy, triple phototherapy, phototherapy blankets. It just depends on how high the bilirubin is and the orders you receive from your pediatrician. So if you have orders to set up phototherapy, you're going to call down to Central and get the supplies you need. It used to be, and in some hospitals it might still be this way, that babies go into the nursery when they're put under Billy lights, but some hospitals will do it in the postpartum room with the parents, which is really nice. As long as we educate them, that's something that we can do. But it depends on the policy of where you're at. So when the baby is under Billy lights, it needs to be naked except for a diaper and an eye cover, okay? Baby's going to be under the lights as often as it can because the Billy lights are going to decrease the bilirubin, right? So you take it out every 4 hours, okay, for feeding. Take it out, put it in a little blanket, take the mask off its eyes, let it open its eyes, and see the environment. Keep it out for a little while, feed it, put it back under the lights, okay? The more it's under the lights, the better. We're going to reposition the baby every 2 hours to make sure we don't have skin breakdown. If you're going to be doing a procedure on the baby, like drawing blood, turn off the lights, and then you can do your procedure. Babies who are getting procedures done typically don't lay still. We really don't want to have them opening their eyes. If their mask comes off, opening their eyes under those lights, it can be damaging to their eyes. Part of our newborn assessment, okay, we need to be monitoring these things while our baby is under lights. And we need to encourage the baby to feed frequently because they pass stool that way. And stool is passed, bilirubin is passed through the stool. So the more the kid eats, the more it poops, the faster the bilirubin goes down, and all is well, okay? So we're going to touch on some more complications that you might see here. So cold stress, we kind of already talked about it, so I think that I'm not going to go over it again. There's something called transitional tachypnea of the newborn. The acronym for that is TTNB or TTN. It just depends on what your hospital uses. TTNB is temporary transition. Transitional means it's temporary, right? So it's not a long-term problem. Basically what's happening is the baby has residual amniotic fluid left in its lungs, and that residual fluid causes these symptoms here, okay? So think about, I'm not going to tell you, but think about the two different ways you can have a baby, vaginal or C-section, and which route would you expect to see more TTNB? I think you know the answer by now, right? So we're going to watch for that, certainly on those kind of babies that were born through that way, but also any baby can have residual amniotic fluid. So we need to make sure that we're watching for tachypnea, grunting, nasal flaring, and retractions. Oh, I gave it the answers right here. Here I was thinking I was being all sneaky. So what's your treatment? Nothing. You got to wait it out. Now, the problem is that this baby who is having transitional tachypnea can't go up to postpartum with its parents. It's not, quote, a stable baby yet. Some nurses, like St. Joe's right now, they have a transitional nursery, so they may admit this baby to the transitional nursery while it waits it out and bring the mom up to postpartum. Other hospitals don't have transitional nurseries, so that couplet needs to stay in recovery until the baby is stable, which means it's come out of its transitional tachypnea, or it is not coming out of it. And now it's not, because it's not eating, and so its blood sugar is dropping, so they might admit it to the nursery then. What I want you to think about is if a baby is breathing over 60 breaths per minute, it can't feed because it can't be breathing that fast and trying to suck on a nipple. It won't be able to do it. So babies who are breathing that fast have to be gavage fed. Well, that's not a stable baby, right? So We're hoping that the time that it takes isn't too long to where the blood sugars drop because the baby's not eating, or the blood sugar or the temperature drops because the baby's not eating. So ideally, we're watching all of those things to make sure that we're keeping the baby as stable as we can while it's transitioning out of this time. Finally, newborn sepsis. I'm not going to hit on this too much, but just a couple of things. I want you guys to know that babies can acquire this bacteria before labor, during labor, and during delivery or after. So it's really important that, of course, we use the best hand hygiene that we can and instruct everybody else that comes in the room to also do that. Infections, because babies are so small, their infections just spread really fast through their body. Just like anybody else who's septic, I mean, you guys have been dealing with adults for a while. You know what the sepsis protocol is. We have a sepsis protocol for this population as well. The final part of this presentation talks about nursing care and discharge teaching. Just like when we talked about in the postpartum lecture, so much of the things that happen in the postpartum period happen when your client's already at home. Well, same thing here, right? If this new family's going home 24 to 48 hours after delivery, a lot of the complications happen when they're at home. So you want to provide our new parents with enough information so they know when to activate phone calls to call their doc and their healthcare provider. So we talk about cord care in orientation. So this is the official slide that goes with it. At delivery, we've already talked about how the cord is clamped and the placenta we get rid of the placenta, but this little cord clamp, which is this little guy here, is going to be in place until the umbilical cord starts to dry off. Ideally, that happens before your baby goes home. So the nurses will, on the postpartum unit, when they assess the baby, as soon as they will assess if the cord is dry, and once it is, they will use these little gadgets we have to cut the clamp off, and then the baby goes home with this little stump here. Okay, so things kind of go in and out of favor, which you know, but currently, the research is saying basically leave it alone. Don't clean it, don't wrap it, don't put anything over it. The only thing we need to do is leave it outside of the diaper and it will fall out on its own. There are some cultures, and I want you to be culturally respectful too. So you're going to have to kind of find your way with that. How do you support your client with their cultural preferences while having the best evidence that says that we shouldn't cover it up? But there certainly are some cultures that put like some kind of support around the belly over the umbilical cord. And so how I would handle that is I would talk to the clients and find out, because I want to support them, find out what this process is that they do and why they do it, and see if we can kind of come to a common ground on that, okay? Babies are not to be immersed in a bathtub for their bathing until this cord falls off, and it typically comes off within 10 to 14 days. So your clients are doing sponge baths for 10 to 14 days. We need to inspect for redness, swelling, and drainage whenever we change the diaper. All right, so babies cry, right? I mean, we know that. The good thing is that you as parents, if you become parents, or your clients, reassure them that they're going to learn the cry of their baby. They're going to know when it's hungry. They're going to know when the diaper is dirty. So the new family kind of learns together. It's important that we know how to quiet our baby. Swaddling is really nice. Babies are used to being in a tight space, so swaddling is really nice. Skin-to-skin contact really helps soothe the babies and helps them to settle. Non-nutritive sucking with a pacifier or the tip of your finger, baby sucking really soothes the babies too. I don't know what this is because my babies are 27 and 25 years old, but I understand that they make things that mimic the sound in utero. And car rides, babies like car rides. It rocks them when they were inside their mothers, and whenever the mothers would walk around, they would get kind of jostled and jiggle. So again, these little jostling and movements reassure them and calm them down. Babies do have a sleep-wake cycle. Babies sleep a ton, 16 to 19 hours. and that gradually gets more and more. But babies typically don't sleep through the night, newborns anyway. It takes just a minute, 4 to 5 months, as a matter of fact. And it could take longer and it could take shorter, right? But on the average, parents can usually expect babies to sleep through the night at about 4 to 5 months of age. We know that newborns get their nights and days mixed up. They don't know what nights and days are. So the research says that we don't put babies on schedules anymore, but we help them learn how to be predictable. Basically, in the daytime, bring the baby out when you're going, when it's the height of the day, right? When things are kind of happening. Bathe them right before to bed so they're nice and soothed. And in the evening time, when it's time for sleep, try to keep them, use low voices, try to keep them not so stimulated. If you're going to feed them and put them back to bed. The less stimulated they are in the evening, just like us, when we wake up, we want to go back to sleep. But if there's lots going on that stimulates us, we tend to fully wake up. So ideally, you want to kind of mimic what you do for yourself for that. Newborns aren't dirty. Their diaper area gets dirty. Their face might get dirty and their neck folds. So bathing doesn't need to happen on a newborn very often. They're not going out and playing in the dirt. They're not getting dirty. Just a couple times a week. Once the umbilical stump falls off, you can put them in a little newborn baby, like bathing tub that sits in the sink. But you can't do that until that cord falls off. Instruct your parents to never leave the baby unattended. If they get to the time when they're bathing the baby and they forget something, you need to pick the baby up and walk with the baby to get what they have forgotten. It does not take long for babies to drown, okay? Make sure the book says 120 degrees or less. Now, there are ways you can look on you can order things that will tell you what the temperature of the water is, okay? Or you can test the water on your inner wrist. Avoid drafts. Think about how babies lose their heat. We already talked about that. If on a male infant, if the baby is uncircumcised, you don't want to retract the foreskin because it can become stuck. So you just want to clean the penis and be done, okay? In female infants, you want to wash from front to back. You can, and parents can, apply fragrance-free hypoallergenic lotion, but no powder. Powder can be inhaled and it can be toxic to the lungs. We want to make sure we're telling our new parents never leave the newborn unattended with pets or small children. I have dogs. I've always had dogs, but I never left my babies alone with them just because it's not safe. Keep small objects out of the reach of the newborn. Newborns should sleep on their back, but have supervised tummy time, okay? And I'm sure that your PEDS teacher is going to talk more and more about that. No pillows, no toys, nothing soft in the crib, just the mattress. No toys, no bumper pads, nothing like that. Some cultures tie something around the baby's neck, and a lot of it's to kind of ward off evil spirits and promote wellness. But you want to have a conversation about how risky that is because it's around the baby's neck. Make sure your house has smoke detectors, that no one's smoking around the baby. All visitors should wash their hands before touching the baby, and people that are around the baby all the time should make sure their vaccines are up to date. Car seat safety, I don't talk about this too much, even though it's one of my hills to die on out in the world, but babies should be in a rear-facing car seat away from the airbags. So if you own a truck that has the mechanism you can turn off the airbag, then you can put the baby in the front seat because it's a truck. But if you cannot turn off the airbags, do not put the baby in front of an airbag. What happens if you have a rear-facing car seat and the airbag goes off, it throws the car seat backwards and it can break the baby's neck. So airbags are super, but they're not good with car seats, all right? Ideally, the baby is in the back seat and in the middle of the back seat. Now, that's if you have like a straight bucket seat, but sometimes people have a hump in the middle of the seat, and it's not really safe to have a baby carrier or baby car seat wobbling back and forth. So if your car has a hump in the back seat, you might want to put the baby on the flat part of the back seat. All right, newborn wellness checkups. After discharge, the newborn should go to their provider's office within 72 hours. There could be some variance. They might want to see them sooner. It just depends, but most commonly it's 72 hours, okay? Just like in our postpartum conversation, we needed to tell our new parents when to call the doctor, when to let somebody know that something's wrong. This is what you need to let someone know, that something's wrong with this baby, okay? So give them the information that they need to provide the best care for their newborn because they're tired and overwhelmed. Encourage parents, anybody who's with that baby, to learn CPR. It's crucial. And this concludes our conversation about newborns.